I didn't want to run the batteries, so.
Well. You just send it.
Good morning. I'd like to get everybody started. Good morning. I want to welcome everybody to our third study committee, Healthcare in Underserved Areas. Gwinnett County is my district, so I'm very proud to invite you all here today. Dr. Jay Denard is the Chief Operating Officer of Northside, and I want to thank you so much for hosting us today. We are looking forward to a very robust schedule and recommendations. We're going to start off with Representative Osteen. She's going to start us with a prayer, and then I would like to go around the table quickly and have everybody introduce themselves.
There we go. Sorry. Before we pray, I would be remiss if I didn't mention that today is October 1st, and I know that our government has shut down, so we need to pray for our national leaders, but it's also Breast Cancer Awareness Month, and our very own chair lady is 8 years free and clear of breast cancer. Yes, that's a praise, right? All right, let's pray. Father, I thank you so much for this day, and I thank you for all the blessings that you've given us. I thank you for the blessings on Georgia. It's been a year since Hurricane Helene, Lord, and we're all still seeing blue tarps where I live and people that are displaced and people that are hurting. So, Father, I do pray that you would be with them. I pray that you would provide for their every need. And I pray, Lord, as we meet today, that we would listen with the intent to hear and understand and try to really figure out how to solve some of these problems in Georgia. So I pray that everybody that speaks will carefully articulate what we need to hear, Lord, and I pray that our ears would be receptive. Help us, Lord, just be your hands and feet. For it's in Jesus' name I ask these things. Amen.
I want to go ahead and get started. We have Jay Denard, the Chief Operating Officer from Northside. He is with Duluth and the Vice President of the Physicians Services of Gwinnett. It's a long way.
Well, good morning. It's a pleasure and a privilege to welcome you all here to Northside today. On behalf of our team, especially Dave Bilber, CEO, who unfortunately had a conflict today, it's our privilege to have you all. From someone who grew up in Perry in Cordova, Georgia, welcome to Above the Gnat Line. We're glad y'all could be here today. Have I already broke something? It looks like I did. Okay. Awesome. How about that? Is that better? We wanted to start this morning with just a little bit about an introduction about who we are in this market, and then also talk a little bit about some of the efforts we're doing around primary care. You are the second audience that is about to see a video that talks about a little project that we've got going across the street. So I just draw your attention to the screen for a moment. There's supposed to be music with this, but I will not sing. But I think you can get the idea. This is our new North Tower that's being constructed. We began this project about 5 years ago to address access for patients that were having to stay in the emergency department without getting a bed, to expedite those admissions as well as discharges. Once the tower is completed, we'll be close to 1,000 beds on this campus. Their first tower was built in 1984. The new central tower that historically had been known as the North Tower was completed in 2009, and then this tower is being completed 2025, 2026. This is our new cafeteria that you're seeing now with all the glass. Our desire was to create somewhat of an oasis for our patients, their families, and our staff, so they could take a moment and get away. And this is the tower. Designed for 15 stories, we're currently at 9. And depending upon certain things coming down the road, when we'll be able to build the rest of the floors. We were going to go to 17 stories, but there's a little issue with Briscoe Field that's very close to here, and that prevented us to go into 17 stories just because of the flight patterns. Located strategically on 316 and 120, it really is the center point. Of course, Lawrenceville is our county seat, but as those of you that know Gwinnett County, we're a very diverse county, as well as we cover a lot of geographic area. With a population of almost over 1 million in the Gwinnett County, we anticipate that we'll be at 1,200,000, 1,250,000 in the next 6 years. It was necessitated that we did expand our bed capacity because our desire is that no one should leave the county for care except for burns and transplants. Since the merger with Northside in August of 2019, just one example of the growth that we have experienced is around our open heart program. When we merged in August of 2019, we were doing about 330 hearts. This past year, we are surpassing 1,100 hearts. That's 1,100 patients that do not have to leave the county, which is also meaning that their families are not burdened with having to travel outside of the county to stay close to their loved ones. But not just open heart. I'll speak a little bit in a moment about the other services that we provide. But we're fortunate that Gwinnett Medical Center was able to merge with Northside Hospital. We're now part of a 5-hospital system network across the Atlanta metropolitan area, but we've also grown extensively our ambulatory network that I'll speak to in a moment. But we're very excited to announce that the second floor of the tower will open in December of 2025, and that's our cardiac floor. Then subsequent floors will open beginning in February through the remainder of next year. But it is more than just bricks and mortar. We dig deep into our services, again, as I mentioned a moment ago, to make sure that patients do not have to leave the county. I'll speak a little bit about the clinical excellence, and we know that what drives that clinical excellence is not only physicians and nurses, but it takes the whole care team. Everyone from respiratory to even environmental services and food services. Everyone that comes together. As we talk about in our employee orientation, regardless of what your title is when you join the organization, you're a caregiver. Everyone is focused on the fact, what we do one patient at a time. Here are some of the services that we offer. I've already mentioned cardiac extensively. We feel like we're very good at what we do, but we're honored the fact that U.S. News and World Reports has recognized us as a high-performing hospital, especially around these areas. This is Northside as a whole, especially with Gwinnett and Duluth focusing on, we're expanding our oncology services with a new radiation therapy vault that's being developed on our campus. Also focusing on preventative medicine, how do we work with folks around diabetes, nephrology, and of course, I'd be remiss if I did not mention OBGYN. We are the largest provider of orthopedic services, everything from sports medicine programs with Friday Night Lights, all the way up to those of you that may enjoy pickleball now and experience, maybe have to go see the orthopedist. We also are a level 2 trauma center. We're very thankful to be able to provide that service and value the relationship we have with the Trauma Commission in the state. as well as our other trauma centers in the state, because we work collectively. If one center is on diversion, how do we work with each other to ensure that we can take care of patients? We are also a level 1 emergency cardiac care center, which ties back into our cardiac program. One of the key things I wanted to point out was that we have on, just at Gwinnett and Duluth, we have over 1,000 physicians on staff, and just this year alone, we've already added 126. I give credit to many things associated with that, but probably the primary reason is the Northside brand. We value our brand, and we feel like the community values it, but we also people value that to seek that out as an employer. As you can see, we have over 7,500 full-time employees in our market. I will share with you that when we merged, we were about 3,400 FTEs. We probably need another 1,000 FTEs just to address the tower, and we recognize the shortages that are out there, and we value the work that the legislature is doing in our state to identify ways that we can improve and enhance partnerships across with higher schools of education, as well as, frankly, even high schools. How do we get people excited about a career in healthcare? But we had over 1.4 million patient encounters this past year here. Just some of the things we do around preventative medicine, because it's not always about just being an inpatient, is how do we work with folks around wellness? How do we address the issue of ensuring that people have well-being? And there are just some of the examples that we do there. But the key here is that we work closely with a lot of community partners to make sure we have the exposure with them around disease management and preventative medicine. I mentioned a moment ago that one of the things we're trying to do is enhance primary care. Depending upon the day, and depending upon the committee meeting or task force meeting, yes, we believe in meetings in the hospital. Depending on the meeting that you're in, the growing need in primary care in our market just continues to be. We currently have a deficit in our market of about 120 primary care physicians based upon population projections. Our goal, we started several years ago, a graduate medical education program focused on family medicine and internal medicine. It's great to see some of our folks from our GME program here today. Of our recent class of the 28 graduates, Georgia did remain. We had 11 who remained in Georgia and 17 go out of state. Because of our family medicine, internal medicine is our primary focus, but we also have transitional year. Our goal is that if we can identify folks who match with us, our goal is that we keep them. If not at Northside, that's our primary goal, but at least they stay in the state of Georgia. Here are some of our access points. If you were in any of our leadership's meetings, especially even the one yesterday, our primary goal, driven by Debbie Bilbrough, our CEO, is access, access, access. How do we engage patients to be access to our services? We've done a lot, again, with bricks and mortar on the campus, but we've also built up our ambulatory network. We've built several medical office buildings around the community, as well as focusing on primary care offices that have a blend, if you will, primary care at the core of that building, and then having timeshares or a rotation of specialists that will come in. Everything from cardiac to OBGYN, orthopedics, urology, and of course a huge need in our communities, I'm sure, frankly across the country. The number one search now for physicians is neurology. We have to do something around neurology as well. And of course, I would be remiss if I didn't mention the fact that we are the baby factory. Over 25,000 births. We deliver more babies than anyone in the universe, and we're very thankful for that. Thank you for being here today. Our staff is here for your convenience, so we can help you in any way we can. Thank you so much.
Any questions? Yeah. Go ahead. Representative Hagan.
Thank you. I do have a quick question for you out of curiosity, your GME program. That you mentioned you had, of your 28 from
this recent class.
So 11 stayed in Georgia and 17 left. Do you know specific reasons why the 17 that chose to leave Georgia did that? I'm just curious if you got any of that information from them.
I'll take a shot at that from the questions I've asked, but I will recognize Dr. Peter Kaplan is here. He didn't know he was going to have to answer a question, but Dr. Peter Kaplan, who is on our staff and is part of our program. First of all, I think part of that is because their spouse or other family members may have gotten a job elsewhere as well, and they go seek that elsewhere. Some also come here from other states as a part of our program through the match, and then they want to go back home. That is probably, I think, but Dr. Kaplan, would you like to comment on any other reasons?
I'd be happy to. 7 of those graduates are doing a transitional year anywhere in the country. So that's 7 of those. So then we did keep 11 out of the other 21. I think, like you mentioned, some of them are family reasons primarily that pull people to other locations once they graduate. And some are young and adventurous and want to try something. We graduated one person who went to Montana, one went to Texas, 1 or 2 went to California. Some of those had family roots there, and some of them were just young explorers. But most of the ones we kept here are from the Georgia area, which is one of the reasons we do emphasize in our recruiting very highly that they have roots in this area, because our goal in GME is to keep over 50%, maybe 75% of our graduates here for this area specifically. Thank you.
I believe, Dr. Kaplan, correct me if I'm wrong, but was it a couple of years ago we actually had a resident who was born at the Women's Pavilion here in Gwinnett and came back here as a residency and has stayed with us?
That's right. That's right. But neither one of us were here yet at that time when she was born.
That's why you're my favorite. Okay. Thank you. Any other questions?
I was just going to piggyback off what Representative Hagan said, is that, and I think maybe you answered that, maybe our physician in the back answered that, is that we're using all of our state resources, whatever, to train these physicians. With the critical shortage that we have in Georgia, I would challenge all of the med schools around here to make sure that there's if they're married to somebody that wants to go back home, maybe that needs to be part of the screening process. You know, I mean, really,
yes.
we need them here desperately.
Absolutely.
And if we're going to educate them here, then we want them to stay here for a short time,
Right.
you know, 3 or 4 years, and give us a try and see if
Right.
they like it, right? So thank you for sharing that, because that's some information that we needed to know.
Awesome. Thank you.
Would you mind discussing just briefly the mobile units that you have, how many and how you use them?
Across our system, we mainly use them for screening mammography. That has been our primary focus. We also had one that we were using prior to COVID and was around orthopedic medicine. And we use those, though, not just for the specific services there, but we take that as an opportunity to discuss with patients that come in is what is the relationship they have with a primary care physician. Our goal, so to answer the number of mobile mammography units we have, I believe is around 4 across the system. We're in projections looking to add that. And we do have the one that we focused on, orthopedics, that we actually are converting now to also help with concussion and do some other things. So I think what we've seen through that, frankly, we're probably going to sell that unit and then try to figure out how to replace it because it's so old. But our goal with that is not only a transactional relationship where someone comes in and is seen from the standpoint of either a mammography or some type of related to Friday Night Lights or something from an orthopedics, but to really just have a conversation with them and explain the benefits of the most precious relationship outside of a significant other is with a physician, a primary care physician. And so we have information in our capabilities with that. We talk about what we provide, not only with our Strickland Family Medicine and our academic internal medicine facility, which is staffed by our residents and the GME team, but also what other primary care offices we have around the community. So that's really been our focus. I will say to you that it's an area that we need to enhance. And it's about timing and priorities, but it's high on our radar to get that. Because many times, I don't know about you on this isn't a criticism, but transportation can be a huge issue, especially in Gwinnett County, just because of the roads and things. And I know you all had experienced some construction trying to get in here this morning. So as much as we can go out into the neighborhood healths, we try to do that. And we also try to figure out how we can partner with the Community Foundation of Northeast Georgia. We also focus in on the Gwinnett Coalition. What are some of the other nonprofits? In fact, last Thursday, we were able, and I see some folks who were there last week, we host, it's called a Northside Conversation, and we bring nonprofits together across the community to really talk about an issue. And one of the issues we focused in on last week was mental and behavioral health. And how can we be more in the communities with that versus trying to bring someone to a central location to focus in on that? And it is a challenge, but we're trying to do that.
Dr. Odom?
You may not know this answer, Jay, so I'm not picking on you, but
Oh, okay.
I've been told that Georgia Medicaid does not cover mobile mammography.
It is not.
Okay.
That's my understanding.
I don't know, but sometimes the people who need the mobile van the most have Medicaid.
And of course, we do not turn anyone away.
Thank you, Dr. Sumner. Any other questions? Okay, thank you so
Great.
much.
Thank you. And thank you for no hard questions. I appreciate that. Thank you.
So next we have Thomas Goss, who is coming up. He is from Navicent, Atrium Health Navicent. I am so sorry. I just totally destroyed that. As you set up, Thomas, do you mind if we just go around very quickly, if you all would briefly introduce yourselves? We'll start over here. Representative Hagan.
Lisa Hagan, I represent House District 156 in South Georgia and chair the House Rural Development Committee.
Angie Gerges. I am the medical director of the Student Health Services at Georgia Southern University and also medical director of Ogeechee Area Hospice, which is our local nonprofit hospice in Statesboro.
We have next to us Leo Chansey. He is the political analyst. Thank you so much for being here. I'm Sandy Donatucci, and I am in District 105, which is in Gwinnett County.
I'm Angie Osteen, District 169, Coffee, Irwin, Turner, and Tift.
Gary Richardson, District 125, part of Columbia and McDuffie County.
Jean Sumner, I'm with Mercer, and I'm an internist.
Thank you so much.
So is that my cue?
That's your cue. Sorry about that.
That is my cue. Well, good morning, everyone. My name is Thomas Goss, and I currently serve as the Chief Operating Officer for Atrium Health Navicent at our Baldwin location. And we've seen many challenges over the past 2 years there, but we'll get into that a little later. First, I would like to share that my name is Thomas. However, there's a story with that. Everyone's always called me Tug. It's T-O-G. Those are my initials. So please call me Tug. Even my mom, most recently, she's almost 80 years old now. She would not be happy if I said that here, but I'm saying it anyway. She tried to tell me that Tug was actually on my birth certificate as well. I assure you it's not. Those are my initials. And early in my adult life, going into the workplace, I was like, it takes too much time to explain Todd. Like, my name's Todd. Oh, Todd. No, it's not Todd, it's T-O-G, Todd, and you explain it. So I tried to do the Thomas thing for a couple of years, just didn't work for me. I'm like, who wants to be another, like, negative, doubting Thomas? Not me. So I'm like, I'd rather be a positive, get stuff done Todd. So please call me Todd. I'm so thankful to be here today. Thank you, Madam Chair Donatucci, and distinguished members of the committee and fellow participants. I really appreciate the opportunity to be here today and address the vital need for improving access to internal medicine in underserved areas. I began my career in healthcare by an accident that I drove up on one day. I actually started working very early in life in a family of construction workers. And when doing that, I started at about 10 years old, and at the age of 19, we were working on some apartment complexes, and the guy that we had hired to be our plumbing contractor had a wife and 2 sons. His name is Ted Hamlin. Excuse me. On October the 19th, 1989, I had left work and I was going to a friend of mine's house, and I rode up on a really bad accident. And it was Ted Hamlin's family. And riding up on that accident that took the life of his wife, his mother-in-law, and both of his sons. At that point, with the paramedics arriving on the scene and the firefighters arriving on the scene, I knew that I needed to do that. And so I began my healthcare career first as a firefighter because I wanted to be a paramedic, so I saw that as a path to become an EMT and paramedic. And I started at the Medical Center of Central Georgia, which is now Atrium Health Navasset, in 1995 as a paramedic. So that was my path to get into healthcare. From there, I went into nursing, where I worked as a trauma nurse in a level 1 trauma center, and then the ICUs, being the educator and manager of a cardiovascular ICU. I managed the ECMO program during COVID, and then from there was director of inpatient oncology at Navasset. About 2 years ago, I went into the chief operating officer role and began my path in really looking into rural healthcare and the needs for rural healthcare. So today, I will use some of that knowledge in being involved with EMS and responding to those calls on an ambulance in areas where you do not have a lot of resources, and you might be 45 minutes from a hospital and having to work a cardiac arrest with a volunteer firefighter in the back of the ambulance with you, and you're just by yourself, basically. So I hope that gives some perspective to kind of where my basis of my information will come from today. It's a 30-year career of being involved out in the community and seeing the needs out in the community and lack of resources. So as you know, for a lot of the numbers that we talk about in meetings such as this, if you guys don't know by my accent, I'm from the north, actually. I went to Montana not long ago, and I was lost, obviously. I'm always lost. I don't like to admit it because I'm a guy, but I asked someone directions, and she said, "Are you from Georgia?" And I was like, "How did you know?" The southern drawl. And it ended up, her parents live on Burton Avenue in Macon, Georgia. I'm like, oh my God, it's a small world. But we talk about health disparities and rural areas and higher rates of chronic disease like diabetes, heart disease, hypertension, renal failure. I mean, so many people do not realize that not managing their hypertension is going to cause them to have renal failure. It's just a snowball, as you guys know. And having access in those communities. We know that access to primary care and transportation, lots of those things are issues beyond the state of Georgia. But in the state of Georgia, in the area that I'm specifically in now, I would like to focus on a couple of areas, Baldwin County being one, because that's where one of our rural hospitals is located in Milledgeville, Georgia. And bordering counties, we have one, Hancock County, that consistently ranks 158 or 159 out of the 159 counties in the state of Georgia. And Wilkinson County also is not very far off from that. In Baldwin County, we have approximately 77,000 individuals in Baldwin County, and we have a total of 7 primary care physicians. In Hancock County, there are approximately 8,500 individuals in Hancock County with 0 primary care providers. In Wilkinson County, we're at about 9,000 residents with 2 primary care providers. So, as you all know, there's a tremendous need for recruiting and retaining physicians in these areas. That's something that I hope that we can work on, but in the meantime, what can we do? And how can we expand services that we already have to reach those individuals? It was very good to hear about the 4 mammography units in this area. I think that's wonderful. We only have one in the Navasot market, in the Middle Georgia market, and that unit began in service in January of 2025. So we only have the one. Since that time, by March, we had 300 screenings completed. In May, we had 500. In August, we broke the 1,000 mark for screenings. And as of yesterday, with the numbers through September, we had 1,178 screenings. But what does that look like beyond just the mammography? So I go back to where I started in EMS. What are the resources we have in place already to reach individuals? I've seen the tremendous impact that putting out in social media and with coverage in the local news that the mammography bus is going to be in the school parking lot at Bleckley County High School on a Saturday or Sunday, and the amount of people that come there to receive those services. I think all of you probably know that on our current ambulances with emergency medical services, we have tremendous resources on those ambulances. With our new LifePak 35s, we can do a 12-lead EKG on a patient and have it read in real time by a physician. It's not a delay. There's not a phone call. It's real time. So how do we go beyond those services? How can we utilize some of the units that we already have in place and take that care to the individuals out in the community? So with my thoughts are, yes, we would like to see maybe some more freestanding ERs or offices, doctor's offices in areas. That would be great. But those are brick and mortar situations, and then how do we recruit and have the physicians or the advanced practice providers in those areas? If we can maximize some of our mobile services that we currently have and utilize a telehealth system with that, we have a lot of the resources. The fact that I've started my career as a paramedic and then went into nursing, it was an eye-opening experience really for a lot of my nursing professors to realize that I had more autonomy and could actually perform more procedures and a more advanced assessment as a paramedic than I could a nurse. So we have providers that are skilled and trained to do assessments and exams that could also communicate with telehealth providers. So that's the mindset that I want to start with here. So going back to the OB mammography bus, I think for here with you guys having 4 in this area, that's wonderful, like I said, but in our area, this is the first time we've been able to do that. So there's just been so many stories. In Hancock County, we had an 83-year-old individual that came to the mammography bus, and it was the first mammography she had ever had. She didn't have transportation. She literally walked like 2 blocks from her house to be seen that day. We also had a patient, a 40-year-old, her name's Lindsay Bowden, and she saw the post on Facebook about the mammography bus being at Bleckley County High School in the parking lot. And a quote from her, she described the process as quick and easy and comfortable, noting the spacious private setup and friendly staff. The next day, she received abnormal results on her My Atrium Health patient portal. That's another part of the story. It's very important to use all of that technology when the patients come to the mammography bus. We help them access that patient portal. We help them get that out on their phone or device, or if they can't do it themselves, maybe their family member with them can help with that. So she was able to get that information the next day and had a follow-up biopsy, and it revealed stage 3 breast cancer. So from there, even though she had had no symptoms, no lumps or anything, she had been relatively healthy. She underwent a successful procedure, a bilateral mastectomy by Dr. Conforti, and with her PET scan that she previously had, it did not show anything. So what would that have looked like if she didn't have that access that day? There's so many individuals of that nature out in the community, as you know. So as we look back into EMS, I was talking with Chair earlier before we started, and I was pointing out someone like me, 56-year-old guy. I live in Jones County. You know, when I was pulling out of my driveway this morning, there were 3 deer right beside my car. You know, it's just great. There's cows right down the street. It's a great place. But if an ambulance comes to my house because somebody else called because I had indigestion, I certainly didn't call because I'm just going to take a couple of Rolaids and let it roll. What does that look like? Well, I can tell you that there is a big difference between, this is my paramedic stuff coming out. There's a big difference between paramedics from hospital-based EMS providers and smaller private services that you see in a lot of rural areas. The training for the hospital-based providers is extensive. The monthly in-service. And the most important thing, having access to your medical director for that service. That is extremely important. Are you aware that a lot of smaller services or privately owned services, they may have a medical director that they've never actually met in person, that may be the medical director for multiple ambulance services all over the place? They really don't have direct access to that. So hospital-based EMS services, in my opinion, are a way that we can greatly impact areas that have access issues. I say that because if you're not familiar, there's a thing on the ambulance that when you run a call, there's a thing called a 1045. A 1045 means that you responded to the patient's location and they decided they did not want to go to the hospital. So I'll give you an example. In January of this year, we were able to expand our EMS services to Wilkinson County. Wilkinson County previously had a private service. The percentage of 1045s that they had was 48%. So think about this. 48% of the calls you go on, you're 1045 in person. So as a medic, I know I worked with a couple of crews that I would be like, oh my Lord, dang, Ed's going on another call, they're going to 1045 them because it seems like they 1045 everybody, you know. You can look at the data and you can see that certain crews may have more 1045s, but you really need to focus on that when you're talking about EMS services everywhere, but especially in the rural areas. The farmer that's been on the tractor all day, he doesn't want to go anyway, so it's not going to do a lot to talk him out of it. So what does that look like? We need to make sure that we're doing a really good job of assessing on the scene and that we are encouraging. We can't make anyone go, and we want to take them to the hospital that they want to go to of their choosing, but we need to ensure that we're not missing anything. So keep that little part in mind as well. Think about it. No brick and mortar. The ambulances are already there. If the hospitals can expand the footprint with their EMS providers to rural areas, like we did with Wilkinson County. Well, now we even see the call volume going up in Wilkinson County because out in the community, people know now that you're going to go to the hospital. You're going to be seen. So what does that look like in the future? For me, I hope it looks like a partnership with telehealth. There is, in my opinion, the only thing holding us back at this point from expanding that is really ourselves. We have the best equipment. We have the highest trained paramedics that you can have. The state of Georgia has a tremendous program for emergency medical providers. The addition of telehealth services and physicians to provide those services will be a lot easier, quicker, and more efficient to have access to those patients in those areas than recruiting and expansion of residency programs, and just there's so many things, and you guys know all of those things. But how can we maximize what we already have? As a provider, a paramedic, there are many times that you know that the patient may only need a initial assessment to realize that this patient is having a hypertensive episode. This patient is having an issue where you might see that your assessment could be that it's possible appendix or something like that, but then you could take the patient in. Can we do house calls with every house? Yes, we can. We do. I mean, we run lots of calls every day. But how do we expand that? Are you aware that in an ambulance service, there's a thing called posting? So instead of just going to the fire station or the ambulance station and sleeping all day, you look at where your volume is in the area at that particular time, and the ambulance goes and parks in that particular area. Well, looking at that data and utilizing maybe AI to assess that data even more, instead of parking in the Circle K parking lot at an intersection, maybe go to the school parking lot a half a mile from there and park there, and not only just be sitting there waiting on a call, but be seeing patients at the same time. Those patients could come to you at that point. They could be, you would be near them in their community. Not only will it provide an opportunity for people to have at the very least an initial medical assessment or healthcare assessment, but it will also help build the relationship out in the community way beyond that, to build trust and acceptance and agreeing that they most likely do need those healthcare services. So there's a lot of upside to that. I would encourage this committee to look into that much deeper from people that know far more than I do on these topics. But I know that the possibility's there. I know that the providers are already in the communities, and it is a easy way to expand our footprint in these rural communities. A couple of other items in closing. We also know that rural patients, and especially men, we do not follow up with our appointments like we should, and we do not get our labs drawn like we should. This would also help with that. In the past, if there was an accident or if you needed to have a legal blood draw for a certain incident or accident that occurred, paramedics and EMS providers do that. So that would just be an expansion of that to help withdraw labs and things of that nature. As far as expanding and having services available beyond that, one of the things we've done at our Baldwin location, in 2024, we were notified that 3 of our 4 OB providers were going to be transitioning out of practice in that area. That left us with 1. And it is a huge risk, as you know, for OB service lines to be closing in hospitals across the nation, much less the state. And we knew that if that service line was closed at our Baldwin facility, that would leave a tremendous desert for those services. So we really started focusing on the importance of just not letting that go away. Am I past time? No. Oh, okay. I might go long, but I don't mean to. I'm like my introduction and like just telling you my Todd story takes 30 minutes, so I'm sorry. So we looked into that and we were able to open a on-site clinic for women's services. We brought in a hospitalist group for OB providers. And what that did is it gave us an opportunity to look at expanding our residency program beyond our location in Macon. And we're working on that. We hope to do that with our wonderful partners at Mercer. I had a GME meeting with Dr. Moore yesterday, but we're looking at that with Dr. Betcher and his program. So we hope to be able to do that. And those are longer term plans and they will work. We have a wonderful state. We have wonderful resources in this state. And I know that as we get more people to come and go to medical school at Mercer, they want to stay. A lot of them want to stay. In the residency programs, they just don't know they want to be at Baldwin in places like Baldwin because they don't have an opportunity to go there and do the residency. If they were there doing their residency, they would fall in love with the place. They would fall in love with Lake Oconee, and they would want to live there and go to school there and stay there. So that's why we hope to expand that. There's many aspects to this, and every idea I think is a good idea. But I think that we should absolutely look into every idea. I know I'm, an old guy standing up here, but I really have a passion for innovation. I'm focused on using and utilizing all of the resources we have with our technology, specifically AI. About 2 years ago, I really started focusing on AI and just thoughts in my mind. This is beyond healthcare. I do have a couple of patents. They're not related to healthcare, but I'm always thinking of what the possibilities are. So when I think of AI, these are just my thoughts. They're not associated with Advocate or Atrium. But I look at it like, how do we utilize AI in an inpatient setting, like for things like central line dressings? Our nurses already have what we call rovers. It's basically just an iPhone that they're doing their charting on, and they can take pictures. So why not take pictures of all the central line dressings and have a quick assessment done through AI that lets you know which lines are more susceptible to an infection based on the way the dressing looks. Also, with our need for specialty providers, what does that look like in the future for AI to help manage some of these chronic disease states that people go to their primary care provider for monthly or quarterly. What does that look like? Managing, looking at labs and managing hypertension, diabetes, things like that. I'm not sure, but it's out there. So in the future, could that maybe provide better access to people in all areas, including rural areas, for internal medicine, family practice? And maybe some of those providers that would do that go into a specialty role where they're desperately needed. I don't know. But I don't think we should rule any of those things out. So in closing, my message today is, number one, thank you so much for this committee. This is an amazing committee. I really appreciate you guys doing this, and thank you, Madam Chair, for this opportunity. This is a forward-thinking, thought-provoking committee that requires all of us to really look at all of the ideas. But let's not forget about the resources we already have. And can we maximize those? I think it's a very quick, reliable, dependable resource that I hope that we can expand and provide those needs to everyone, not only in the rural areas. You think about overcrowding in ERs. How can this relieve some of that as well? So again, thank you for the opportunity today. I'll be glad to take any questions, and I've enjoyed being with you today.
Todd, thank you so much. Does anybody have any questions?
I wanted to get a little clarity on the EMS and just make sure that I was understanding. So you were talking about the hospitals owning the ambulances, or the counties owning and running those, or you talked about the private, operators or whatever. So just fill me in, because from where I'm located, our hospitals don't own ambulances.
Yes, sir.
And so who would do that? I don't know that the counties, from what my understanding, every county is probably short ambulances.
Right, exactly.
And even the ones that are doing it with a private service.
Yes, sir.
And then if you're tying up an ambulance, seeing people while they're sitting,
Exactly.
Then all of a sudden you have a 911 call. What do you do with the person that you're having?
Exactly.
That's just it was a little broader, and I didn't have my head wrapped around it.
Absolutely. I appreciate the question. It's a great question. And as you know, no matter what we do as we move forward to provide these services, it will take financial resources to do that. Whether it's, like I say, freestanding ERs or doctor's offices or whatever. So to answer your question, I was speaking basically about our hospital EMS service. However, I do not feel that it has to be hospital. It can be county. It can be a private service. My point is that the local hospitals in that area certainly need to be highly involved with any of those services. Where those services have the resources that they need, going back to maybe those smaller private services do not have the cardiac monitors or some of the devices that they would need to be on that level, so they would need extra resources and assistance to do that, whereas most of your hospital services would probably have those things. County services might need some assistance as well. So from a standpoint of how do we stand that up and assist with that, I think as maybe the state, we could look into what type of resources could we provide to ensure that any of those services that meet the requirements laid out by the state or the committees that would have the resources to have those heart monitors or whatever equipment is necessary. I hope that answers.
Well, it does a little bit, with the exception of all of the rural hospitals that I hear about are struggling to provide, and they're having to raise their tax rates, you know, to keep the local hospitals open. And then if you're adding that on top of it, I'm wondering if the small, poor communities, taxpayers, can afford to do that and continue to keep the hospitals. It's resources does a lot for everything.
Yeah, absolutely.
I guess so.
Yes, sir. I agree. I think that financially, it would most likely be less of a cost to add 1 or 2 ambulances and the staff and equipment that goes with that, and being able to reach the people rather than a whole building or unit and things of that nature. There's certainly going to be a cost with anything that we do.
Thank you very much.
Yes, sir.
Lydia Hagan. Thanks, Chair. Thank you for your presentation. And that's a very interesting idea. And so what I wanted to share with you, Rep. Richardson, along those lines is that a lot of these rural hospitals that we're talking about, even when they have county transports or EMS, there's a major problem transporting patients out of those rural hospitals to another hospital, get a higher level of care, because the EMS service does not want to leave the county. Now, my problem with that is, I know that they're there to serve the citizens of their county, but it's most likely one of their citizens that is in that hospital needing to be transported. So that is a concern I have. But for that reason, there are some small rural hospitals that have purchased an ambulance to use solely for the purpose of transporting patients that need to go to a higher level of care. And I'm just thinking, you know, that's an interesting, creative way, maybe with a little bit of resource input, to use that transport that they're already buying, because they're looking for more patients. They need to build relationships so that the people in their community aren't going out to another hospital. They want them to go to their hospital because they're desperately trying to stay in business. But I think, so there actually are some rural hospitals that have had to resort to buying an ambulance just so they can transport, unfortunately, because of the distance to that higher level of care. So that might be a creative way to make better use of those while they're sitting waiting for somebody to transport. Because you're right, I hadn't really ever thought about that. They're just frequently just sitting in a location waiting to get that call. But if they could be making some good use of their time while they're doing that, that's interesting. How that helps.
To that point, if you don't mind, to that point, we have what we call state of readiness. So, for example, Baldwin County contracts with Atrium Health Navicet to provide 3.5 ambulances in a 24-hour period for 911 coverage. For the contractors for 911 coverage, it's 3.5 ambulances. If one goes on a call, then you're at 2.5. So you're not really at the 3.5 that you're contracted for, but you're running a call for someone in that county. And to your point, the patient that comes to Atrium Health Navicet Baldwin, if they need a higher level of care, then we take them to Augusta, Athens, Atlanta, Macon, but we're still servicing the members of that community because that person is of that community. So that's a great point that you made there, because we do need to consider that yes, that might take us below our state of readiness of where we try to be with a particular amount of ambulances in a community, but that ambulance is still servicing the member of that community even though they're on a 4-hour transport. So thank you for bringing that up.
Dr. Odom.
Chairman, thank you. And thank both representatives. I think when we write up our summary, I think we've had 2 talks about transport, and I think that's a very important thing. I work in a Hill-Burton hospital 2 days a week, and I've been transferring patients to myself for 30 years. So I see it on both sides. As we fight to keep these small hospitals open that don't have specialists or don't even have internists, and we got to transport patients. We need to keep those hospitals open. They have to be kept open. But patients have to be taken to tertiary care centers, and that delay is often 24 hours. And I don't have a solution, but I appreciate y'all for bringing it up as a problem. And throwing money at stuff is sometimes not the best solution. But I think when we summarize our findings, I think the problem of transporting patients from rural communities certainly needs to be brought forward, and I appreciate it.
Dr. Odom, thank you. And just to comment on that, last month we transported out of Baldwin, our location in Milledgeville, 172 patients that needed either a GI consult, neurology consult, or infectious disease consult. So a couple of months before that, I had a family member that was at the location at Baldwin, and they needed a GI consult. Nothing major, just needed a consult. So we transferred my family member from Baldwin to Macon. When my family member got to Macon, they never saw GI. The hospitalist managed it, right? Was the same hospitalist group that we actually have at our Baldwin location. So I started looking into that a lot more. I think that's something very important that we need to look at, because a lot of times I have seen, if it's something like infectious disease or maybe a neurology consult because of a seizure, or maybe that patient that was just started on Eliquis that might have a little dip in their blood count, but really not seeing anything beyond that. Are those patients being transferred to a higher level of care, but the hospitalist team is still managing, or are they actually being seen by the specialist? And I think there's a gap there.
Certainly you need to look at unnecessary transfers, but the ones I were talking about are people who need emergency surgery.
Yes, sir. Yes, sir.
I think, oh, excuse me.
No, go ahead. Last question.
Often, I think, thank you, Doctor.
Oh, yeah, thank you, Dr.
But sometimes it's not the ambulances, there are not enough beds, or they don't have enough nurses to cover the beds there. And so I think a deep look at the delay, because the delay can be that they don't have enough nurses to cover the beds in the unit or something. And really, so it's not just about ambulances. I mean, it's an issue, but the delay can be terrible. So.
Thank you. I really appreciate it.
Thank you so much. This has been a very good conversation. Tog, thank you for coming today.
I appreciate the opportunity. Thank you.
Absolutely.
So much.
And with that, we are going to move to Georgia Public Policy Foundation. This is going to be Chris Denson. Chris, thank you so much for coming, Director of Policy and Research.
While we're waiting on somebody to come up, may I just make a comment? So I'm pretty sure that my hospital at Coffee, we, for lack of a better word, decommissioned an ambulance, and we donated it to, and if Vicki Lewis is watching this, please correct me. We donated that to the local technical school where there is an EMT paramedic program, so that they could have an ambulance to train on. What if we considered those where we have all these TCSG schools and where they're training paramedics and EMTs, we use those that have the ambulance to go and out into the field and have a paramedic go with us. You know, I don't know. I was very fascinated with that idea of using the ambulance as a mobile unit for a certain period of time. Thank you.
All righty. Thank you. Good morning. My name is Chris Denson. I'm the Director of Policy and Research at the Georgia Public Policy Foundation. I'd like to thank Chair Donatucci, committee members, and Leo for his assistance in getting us all here today. So thank you for your time. We're a nonprofit think tank. We focus on economic policy. We were established in 1991. We also have a 501c4 affiliate that advocates for certain issues that we work on. And personally, before I joined the foundation about 5.5 years ago, I spent about 5 years at a rural hospital trade association, about a year or so at Memorial Health down in Savannah doing rural health outreach, along with some time on the staff of a U.S. Senator in D.C. and working for an HHS secretary focused on rural health issues. So spent a lot of time thinking about this issue and just how do we preserve access to rural health care, especially here in Georgia. I believe you've seen this data previously in this study committee, but it's worth reinforcing while we're here today. You'll see that the overwhelming majority of our state, even in metro Atlanta, are considered health provider shortage areas. Over 2.75 million Georgia residents live in a HPSA. You can see where the Navy is here in the state. And then there's some data as well that shows that Georgia is projected to be short over 8,000 doctors by 2030. I believe you've heard some of those trends and reasons why, but it's an aging physician population. And something that will come up here later today is, as a country, we actually produce more medical school graduates than we have federally funded residency slots. So I believe you heard last week that we're capped based on 1990 population numbers. So these are some issues that are creating a bottleneck in terms of getting more physicians out into not only rural Georgia, but really across the country. So as you heard Chairman Parrish mention last week, the state legislature inserted additional funding for residency slots both into the amended 25 budget and the fiscal 26 budget. And it was around a year or so ago that I was thinking about, in terms of what we do as a state and the funding that we provide for residency slots. And I was having this conversation with a former state legislator who is also a rural physician. And he pointed out to me, he said, it takes roughly 7 years of training to produce a physician. So even if we fully funded all these slots, you still have a lag in terms of getting these physicians out into these communities. And so the premise behind what I'm talking about today is essentially what are other states doing to supplement the traditional physician in underserved areas. And so you'll see up here today, I have 4 things outlined. The first is this concept of expediting the path to practice for internationally licensed physicians. The second is the creation of assistant physician programs. And these last 2, I'm not going to spend time talking about today. For those of you who are veterans of the legislature, you'll know that these scope of practice issues are sometimes political third rails. But the first 2 really utilize medical school graduates. So I'm going to focus on those 2 today, but if anyone's interested in learning more about bullet points 3 and 4, I'm happy to have that conversation. Before I move on, I will note that currently 28 states and the District of Columbia allow for nurse practitioners to independently see patients. And then 5 states in recent years have started allowing pharmacists increased scope of practice to see patients. So as well, and I'll move on from there, but if you have any questions, glad to have that conversation offline. Okay, so this first one, internationally licensed physicians, because it's healthcare, we have to have an acronym, ILPs. They're also referred to as foreign medical graduates, internationally trained physicians, but this is a concept that has really grown like kudzu in recent years. I remember I was at a conference in early 2024, and at that time, Tennessee was getting ready to launch the first in the country version of this program. Since then, I believe we have, I know I have it on a future slide here, but 18 states have since implemented a version of this law on their books in the last couple of years. And so what the program is intended to recognize is that we have immigrants, legal immigrants living in the country that have been practicing physicians in other countries. The very common story you'll hear is they're here in the US working as Uber drivers. And so, there's this idea in policy circles that how do we utilize their medical experience and get them from working in the service industry and get them back into the US healthcare pipeline. The second point here I'll notice is, if you're talking about let's just say it's an orthopedic surgeon, an oncologist, and they're practicing in the United Kingdom and they want to practice at Emory, for example, they still have to go through the same residency program in Georgia that a medical school graduate goes through. And so that's part of the reason why Tennessee and these other states have said, hey, this is, somewhat redundant, especially when you consider the fact that we have this bottleneck of more medical school graduates compared to residents. And so why do we have trained and practicing physicians competing for the same residency slots as fresh medical school graduates? So when thinking through the utilization of these ILPs, there's a couple things to consider. One thing obviously is when an immigrant goes through the migration process, it takes several years to attain legal status. And so a lot of these states are tackling how many years do we want to essentially provide a grace period in terms of looking back, have they been out of practice? If a foreign physician has been out of practice for 10 years, maybe that's not quite the same as a foreign physician that's been out of practice for 1 year. Maybe they need to go through the traditional residency program. So you're seeing a lot of variance in terms of the way states are tackling this window of what's called a look-back period. Another thing as well is that a lot of states are requiring these international physicians to already have a job offer from a hospital or a health system before they allow them to enter this program. There is a version of this bill that came up in the Georgia Senate in 24 and 25, and it was essentially 2 tiers. So the first was the provisional license. And so for 2 years, you would be, if you're a foreign physician, you'd be employed at a hospital or a health system. Some versions of the bill expanded the definition where you could be a federally qualified health center or at a university, like in a teaching position, to ease that transition into the intricacies of the American healthcare system. And then after the successful completion, everything goes well, you have good letters of recommendation, you would then enter a 2-year period in a provisional license, under a provisional license, and you would then have the ability to practice a little bit more independently, but you're still working in a medical underserved area or a health provider shortage area. And so then after that, you'd have the ability to apply for a full license through the Georgia Composite Medical Board. There are a couple of, in diving into this issue over the last couple of years, one kind of common misconception is that, it seems like everyone seems to have this anecdote of, they know somebody that applied for med school in the US, they didn't get in, they went to the Caribbean, and then they're just going to come back here and essentially bypass the residency program and then start practicing as a physician. I mentioned some of the safeguards in place, such as the look-back period. A lot of states are saying, okay, you have to practice for X number of years before you can even be considered. So there are a lot of rules and regulations put in place to safeguard against that. Another kind of common concern with this program, and I think this is pretty consistent across like the healthcare system when you talk to people that are recruiting physicians, is that we have an accrediting body for medical schools around the world. That is the Education Commission on Foreign Medical Graduates. So they're essentially evaluating, is this a quality accredited medical school? We don't really have the same level of breadth when it comes to evaluating residency programs. So you're seeing a lot of states kind of put in some qualifiers in there in terms of allowing for leeway within their state medical boards to evaluate the quality of the candidate because, for example, we have the ACGME, which is the Accreditation Council for Graduate Medical Education. That is how residency programs are accredited here in the US. They have an international arm, but for example, they only have accredited 22 sponsoring institutions, so 22 residency programs in 12 total countries. So from that standpoint, you're seeing a lot of states almost having like a set list of countries they're accepting international physicians from. And they'll typically Western European countries are more popular in terms of set space. But that's kind of just to keep in mind the quality of the candidate you're receiving. The last criticism you often hear around these programs is that there's no path to board certification for a foreign physician when they come here. A lot of hospitals and health systems will require physicians to be board eligible at the minimum when they come on. And so in the last couple of weeks, interestingly enough, for the purposes of this committee, the American Board of Internal Medicine has announced a pilot program to help facilitate foreign internists to become board certified if they meet a certain set of criteria. So they're recognizing the growth of programs like this around the country, and they want to help facilitate ensuring the quality of candidates through the Physician Society as well. Here you'll see a couple of our neighboring states that have adopted programs like this. That first bullet point, that was 18 states. What that essentially is, if you go through the kind of provisional license, the limited license portion of programs like this, there is a pathway to a full license to practice independently, typically in a medical underserved area, without undergoing the traditional residency. And then you'll see we have, 3 neighboring states here that have already adopted this. The second bullet point, you'll see these are the states that have legislation like this under consideration. As I mentioned, Georgia has considered this bill in 24 and 25. And then the last point here, there are 3 states that have implemented a program like this, but they don't actually have the pathway to a full licensure at the end for international physicians. So you can come in, you can practice under a limited and provisional license, but then there's no transition to actually allowing them to practice independently. The second program, as I mentioned, are assistant physicians, associate physicians, and I think there are about a dozen different names for this program that are popping up around the country right now. But this came about, it first passed in Missouri in 2014. There was a state representative who was also a rural physician who recognized that he was encountering medical school graduates who did not match his residents. And he documented the kind of financial and emotional strain from that. And he thought, we need to put them to work somehow into our healthcare provider pipeline. And so what you're looking at here is, okay, like you have not matched as a resident. And typically what they'll allow you to do is to work as essentially almost like a PA or an NP under physician supervision for a year. Some states allow up to 2 years, some allow to 3. And then there's this limited scope of practice that they allow for these assistant physicians to undertake. The other third kind of common criteria you see is this requirement to practice in rural and underserved areas. So they're essentially taking them and putting them out into where they're most needed in that year or two while they try to go through the residency application process again. For example, I've written down a few things about Missouri because it was first in the country. But so an assistant physician enters into this collaborative practice agreement with the supervising physician. The supervising physician is required to review 10% of the AP's charts every 14 days, as well as 20% of the charts where controlled substances are prescribed. Additionally, the supervising physician and the assistant physician must complete 1 month working together continuously prior to practicing at different locations, and they must complete over 120 hours of on-site practice prior to the assistant physician being allowed to prescribe controlled substances. So Missouri, which I said was a physician-crafted law, had put several safeguards in place. But from a high level, there's a lot of variance in terms of what you're seeing across the country when different states develop these programs. That, I'll go to my next slide. So for example, you're seeing some of these APs being able to practice for 1 to 3 years. Some of them, you can renew your license once, twice, not at all in some instances. And so here you'll see our neighboring states as well that have adopted a version of this program. Again, we have 3 neighboring states. The only difference here this time is that Alabama takes the place of North Carolina, Tennessee and Florida, the 2 common denominators here. We have not had a version of this bill introduced yet in Georgia, but in the interest of full disclosure, I have spoken with several of your House colleagues that have expressed an interest in exploring this concept and introducing a version of this bill in 2026. The other thing I'll note is that this idea of assistant physicians, you're essentially taking physician assistant and you're flipping the words around. It can be pretty confusing. So just some examples we're seeing across the country in terms of other names: bridge year graduate physician, graduate assistant physician, special permit, supervised medical graduate. So it's just another example in which states are really kind of inserting their own flavor, and there's no one size fits all that we've seen across the country in developing these bridge year programs for unmatched residents. And then lastly, and this might flow into any kind of questions you might have about assistant physicians in general, but what you're seeing, one other consistent theme you're seeing across the country is that as states are looking into implementing these programs, they are viewing them as like a bridge year. What you're then seeing is states that have these programs on the books for several years, like Missouri, are then saying, okay, we have medical school graduates that have found they enjoy being an assistant physician. They don't really want to undertake the traditional residency. So how do we either have a path to full licensure after like 5 years of doing this? That was one bill that was introduced and did not pass in Missouri. Or how do we allow an option for them to continually renew on an ongoing period? So they're under review with the Med Board, but they can stay in this collaborative partnership agreement similar to a PA or a nurse practitioner. Lastly on that one, as I mentioned, there are multiple variances in the way states have implemented this program. I'd be happy to provide like a written landscape analysis that we've done to Leo to share with the committee. You can see, as I said earlier, the way the states have really inserted their own kind of specifications in there. But with that, I'm happy to take any questions that the committee may have. And I know those are 2 pretty dense concepts I had to cover in a short period of time, but I appreciate your time today.
Any questions?
Yes.
Representative
Angie.
There you go.
Thank you, Chair. This is fascinating information. I'm sure Dr. Sumner probably could expound on a lot of this, but kind of honing down onto 2 things. One, by 2030, there's 8,000 physician shortages, right, in Georgia?
Yeah.
How many physicians do we churn out that are ready to go to practice every year in Georgia? Do we know that number from our medical schools?
For medical schools, it's, I believe.
How many do we have?
It's about 800, is that right?
800 a year we're producing right now. And so just short numbers, that's 2,000 a year by 2030, starting in 26. Mm-hmm. So we're not graduating enough, we're not admitting enough, we're not training enough. So what prevents a med student from matching? When we've got these unmatched students, what prevents them from matching?
So there's the like high level, right, where you have more graduates than you have residency slots total. There is the issue of candidate quality as well. But in terms of Georgia, for example, when you go back to like the shortage you were asking about, we don't have enough total residency slots commensurate to the amount of medical school graduates we have. But more importantly than that, we are pretty we're significantly low at retaining Georgia medical school graduates into Georgia-based residency programs. And I don't have the numbers in front of me right now, but it's just like a force multiplier in terms of when they practice in Georgia, graduate medical school in Georgia, do their residency in Georgia, staying in Georgia. So, and we have a couple of physicians on the committee that can, probably speak a little bit more intelligently about that than I can. I saw Dr. Odom's hand.
It's just such a shame that you get to that point to match, and then you're, one of the rubrics is you're a low-quality candidate.
And let me say too, I believe y'all touched on this last week, but Congress felt like there was an overpopulation in terms of medical school graduates in the 90s. And so they capped, based on mid-90s population numbers, the distribution of Medicare-funded residency slots. So states in the Northeast and Midwest that have had declining population for decades still have the same number of residency slots, whereas Sunbelt states like Georgia that had a surging population, we had 1 million residents per decade, have not kept pace with that. And that's a big federal problem. But I've had conversations about that with people in DC. Here's the problem, it's bipartisan in terms of preserving the status quo. Because if you're a Republican or you're a Democrat and you're in, let's say, Ohio, you recognize your population is declining, you still want to keep those federal dollars flowing into your state. And so we haven't had enough of a population shift in terms of congressional apportionment into the Southeast and the West to overcome that yet. But I mean, that's a significant problem when you think about getting physicians to where people are right now.
Yeah, no wonder they shut down.
Dr. Odom.
I enjoyed that greatly. And, they say there's nothing new under the sun. We're going back to the early 1900s where it was perfectly okay to train by preceptorship. And having rotated with doctors in my youth that trained by preceptorship, I didn't notice any difference. But we tried to standardize medical training in this country, and now it's broken. The reason my students don't match is because they want to be brain surgeons or dermatologists, and there's too many of them that want to be that. And so it's become quite competitive. Meanwhile, a lot of these students would be better off as internists. So
Does it become a reality?
we scramble. We call it a scramble. Dr. Sumner can tell us all about it because we're judged as medical schools when our students don't match. That's a bad mark. So we go into this wild thing called a scramble to get them a job. And 99% of them get a job. Well, I wanted to be a brain surgeon. Well, we got you a job as an internist in Douglas. Well, they are. A lot of times they are. And strangely enough, when they start that, a lot of times they go, this is pretty cool. Maybe I was too immature to decide what I wanted to be. So actually, their failure to match into these big old specialties is turning out to be probably an unintended consequence of there being too few residents. In other words, I see it as more getting pushed into primary care because of inability to become ear, nose, and throat doctors. So that's not as big a problem as I think it is. But what really interests me is this learned gentleman talking about going back to preceptorship. I can't wait to hear what Dr. Sumner has to say about it.
And Dr. Odom, I double-checked the list of the 14 or so different names for that program. There's not an apprentice physician listed, but I thought for sure there was going to be after you said that.
Sort of like a jackleg lawyer.
Dr. Sumner.
Dr. Sumner's not going to comment on that, but the match is the real reason, like Dr. Odom says, is you have a student who, and these are adult people by the time they finish medical school, but their mama told them they could be a surgeon. And we've had very bright students who do well, but they don't meet the criteria, turn down opportunity after opportunity after opportunity, and finally to say, well, maybe I shouldn't be, and then they match. I think our match this year was 99.3. 2 years ago, we had 100% match. I mean, it's counseling these young people from day one what it takes to get in. Some of the subspecialties, those specialties are really restricted, and they are narrow, and they don't want to grow, I guess. They make the criteria so difficult.
Who is they?
The actual residencies, or whoever runs the residency has, they want 10 papers, research papers, and they want these things. I mean, they want so many things, these young people can't meet them. I think, too, that we're turning out more doctors than we see. I think the medical college class is now 300 students, and ours is 180, and I think Emory's is over 100, but I don't know about, and Morehouse is over 100, I think. I'm not sure on those numbers, but it's more than that. And I'm not, I'd love to have a conversation with you about it, that you can actually come as, if you finished a residency in Europe or in quality schools, you can actually get an institutional license in this state. It was created during the Gulf War, I think. I mean, we resuscitated it during the Gulf War is what we did, because we had doctors who were very well trained that fled Iraq. They were trained in Europe and England, and they were delivering pizza in Atlanta. So we offered them, we took that license and reinstituted it. The license belongs to the doctor and the institution, so they can work in public health, they can work for a hospital system, and the VA, they can work for a number of systems. It's an unrestricted license, full license. And I think one benefit to that is the practice of medicine coming out of medical school. You train for what? How many years? 20 years. I mean, you're ready, you've covered that. But you walk in to see your first patient, and you feel about as unprepared as anybody can. And there are things that you do not see in a tertiary care hospital that walk in your office and you have no clue, and you need experience. And residency gives you experience. And that even happens when you finish your residency. You walk in, seeing real humans that you're ultimately responsible for is daunting. One of the problems, there are some great doctors around the world. And fortunately, some of them have come to America. But understanding the culture, understanding the language, understanding process is really important, because you can hurt somebody very easily. And so I think it's important to really not think, and I hate a turf battle, but it's really more than that. It's not a turf battle. It's quality of care and safety. And a physician who trains in another country who comes here, it is true they have to do 1 year to get licensed. 1 year. They don't have to do a full residency. The problem after that is, if a lot of times they don't do a full residency, the insurance companies won't credential them. So, and I suspect they wouldn't credential these guys. I don't know. Maybe if you pass the law, they will, but it's hard to get credentialed. That's another story. But I think most young people who listen to their academic or the student affairs advisors do very well. I mean, they, and so I don't think many people finish 4 years of medical school, because it's rigorous, and you go through the same national test at every MD program in the country, and so you know where you rank and that sort of thing. So.
Yes. Okay.
Thank you. Thank you so much.
Did you have? Okay. Next, we have the American College of Physicians, the Georgia chapter. Teresa Rohr Krogerber. Do you need chairs?
Hi, I'm Omama Romani. I'm currently a third-year resident at Northside Gwinnett.
Hi, I'm Dan Zlatopolsky, currently a third-year medical student rotating on internal medicine, also at Northside Gwinnett.
Hello, my name is Afsa Hussain, third-year medical student at the Medical Partnership in Athens, and I'm also rotating in internal medicine at Northside Gwinnett.
Thank you, thank you. And I thought it's incredibly important for them to be here because some of the concerns that we have in terms of providing medical education and obtaining residency, et cetera, are things that they can directly talk to today even. So I'm Teresa Rohr-Kirchgraber. I'm a professor of medicine at the AU-UGA Medical Partnership. I have been on medical faculty in many different locations, but back to Georgia since 2021, and am currently involved with the American College of Physicians, the group that puts together internal medicine physicians across the country, which also includes not only general medicine, but also subspecialties. So I wanted to talk just a little bit about medical school applicants in Georgia. I think we have a phenomenal program with our public medical schools as well as Mercer. With those, with the Medical College of Georgia and with Mercer, almost 90% of the seats that are allocated are for Georgia residents. This means that our Georgia residents who go elsewhere for undergrad come back to do their medical school at MCG and at Mercer, and we specifically look for those students who have residency in Georgia. Now, my numbers are a little bit different than Chris's earlier, and I believe these are pretty correct, but if you look at all the medical schools in the state of Georgia, we have about 750 slots. That includes PCOM, the osteopathic school, as well as the MD schools. If we just look at, for example, MCG, which is the state-funded medical school for the state of Georgia, we have about 3,000, 3,200 or so applicants every year. Of that, we take about 304. Now that number will increase, hopefully, as the UGA School of Medicine comes into being. If you look at some of our private medical schools, which take people from everywhere, for example, Emory, they get about 12,000 applications per year for their 150 slots. For every person who applies to medical school, the average is about 16 schools that they apply to, because you're never guaranteed anything, so you're going to play your odds as much as you possibly can. But we have, I think, a phenomenal number of pre-med students that are smart, that are willing, that want to stick around. I think when I was at a recent AAMC meeting, the American Academy of Medical Colleges, and I mentioned that we were going to be increasing the size of medical school classes, a person from Alabama goes, well, how are you going to get those applicants? I was like, not a problem. We have enough to go around, and more than we could possibly hold right now. So why do medical students want to stay in Georgia in the first place? Okay, well, we know that about 38% of practicing physicians will come back to where they did their medical school training. Well, part of that's because if we are a state institution and we take our own residents, even if they go away for residency, they want to come back because this is where their family is, this is where their community is. In fact, I had one just yesterday who was at the house, and he did his medical school in Athens. He was one of our graduates. He went away for residency, but he had such a great time in Athens that he came back and has established his practice here and brought his family here. One of the biggest draws is the tuition. As a state institution, Georgia helps to cover our tuition, and that makes a huge difference. The average cost for an in-state person is about $32,000, and then you add in, cost of living, et cetera, it ends up about $50,000. For many private schools, it starts at $50,000 just for tuition alone and can go as high as $90,000 per year. So for us, the average student who's graduating from a public institution in Georgia usually has about $200,000 in debt. That's for those people that are taking loans and scholarships. About 70 to 80% of our students, and medical students everywhere, are on some degree of financial aid, with the average medical student graduating at $250,000 in debt. educational debt. And you're going to say, well, you know, how can we mitigate that a little bit? Well, one of it is the local regional campuses have done a lot to increase the financial affordability. You know, for example, I have a small group. We do small group learning with an MD, PhD, and we have 7 or 8 students. 4 of those students are actually driving from Atlanta to Athens every day. They're close enough that they can combat some of that cost of living by actually living at home and traveling. So the regional campuses can do a fair amount. But there are some hidden costs. I think we can talk to our students about the hidden costs. They are based in Athens, but travel to Northside to do their clerkships. And that happens everywhere. And it's encouraged because we want our students to experience other things. We want them to go to Albany or Milledgeville or someplace else so that they can get that experience of being with a smaller community and a smaller community practice. But what we don't do is then incorporate that cost of transportation back and forth. But also, you know, somebody mentioned about the match and getting into residency programs. Absolutely. Well, some of that is you have to have scholarly activity. Well, how do you get that scholarly activity? One is through research. Another is through publications. And so we work really hard with our students to get them case reports, poster presentations, things like that at national and statewide meetings. But that comes with a cost. Medical schools don't have, by and large, extra funds to send their students around the country presenting, where they're going to get exposure, where they're going to network, where they're going to be able to put documentation of their scholarly activity on their CVs when they apply for residency. Every time you submit an abstract, it usually costs you about $50. Sometimes they get a publication, it can cost $1,000. So there's definitely a cost associated with these things. What about other things like health insurance, for example? Health insurance, every medical student has to have health insurance. When I did a study looking at different states, what we found was that some places, they actually had a much lower cost for health insurance because they expanded Medicaid in that state. When they expanded Medicaid in that state, their students were eligible for Medicaid, which lowered their actual costs. For us, if we have a student that's over the age of 26 who's no longer eligible to be on their parents' insurance, even if their parents had health insurance in the past, that cost can go up to almost $6,000 a year that's added to your educational debt. Away rotations. In order to get a match, you want to do neurosurgery, you need to do some away rotations. There's only 2 neurosurgery programs in the state of Georgia. You might need to go to New York or Boston or California. That's on your dime. We don't cover that. You have to find your own location, you have to find your own housing, you have to find your own way there. But then there's also all the fees for all the licensing exams. The board exams are, they can be anywhere to a couple $100, but even still, that's also a cost that's not included in the overall cost of living and in your tuition. Residency application fees. A couple of years ago, I was on a website and finding that medical students were complaining, not just ours, but elsewhere, that they were taking second jobs, working as a bartender, working in a coffee shop, just to get the fees that they needed to be able to apply for residency. But why don't they match? Well, maybe they couldn't afford to apply to the 50 programs in Opto, so they only applied to 10 and they didn't match. We actually started a program with another organization to help reimburse students for those. So all these medical school graduates, about 750 in the state of Georgia, where do they gotta go? They have to go to a residency program. And I thank Georgia for its insight to recognizing that this was going to be a need, and then back in 2013, 2014, creating the GREAT committee, looking at how to increase the number of residency slots in the state. And I appreciate my dean, Shelley Nuss, and her participation in making this happen, because we had to find workarounds in order to get new residency positions since we were not getting federal funding. So currently, these are the number of PGY slots in Georgia, about 930. So about 750 medical students coming out, about 930 residency slots. Now remember, those are not all equal. I mean, we have a couple of plastic surgery positions. We have a lot more internal medicine residency programs. So in the state of Georgia, in theory, there's enough, but
Not every resident is making just these choices. And we have in our, last year we had five medical students that wanted to go into orthopedics. Well, there's not that many slots there. Now, if you look at the internal medicine, you go, yahoo! I mean, I do when I see that number, hooray, that all those people want to go into internal medicine. But when you talk about primary care, only about 2% of those who are in residency are planning on primary care. But thank you to our resident who is planning on primary care, so you can tell us a little bit more about that later. Now, you might think too, well, now they're done with medical school, now they're making money. That's great. The average, about $63,000 per year, that the range can be in the state of Georgia between about $52,000 to $72,000 a year, which again, doesn't sound so bad. But remember, this is with an 80-hour work rule restriction. That means that the residents can't work more than 80 hours, but the expectation is they're working 80 hours. So $63,000 a year at 80 hours a week, you're making $15 an hour. Now, I recognize that the minimum wage in Georgia is much less than that, so they're making more than minimum wage. They are making much less than the nurses that they're working alongside, than the physical therapists, and in many cases, even than the janitors that are in the hallway. And they do this for anywhere from 3 years to 7 or 8 years, or even longer if they're doing fellowships. Now, some of the new rule has it so that if you have a loan, a medical school loan, you are now having to repay that loan while you are in residency. So you're $250,000 in debt, you're making $15 an hour, and you're having to repay your loans, or that interest continues to accrue. So what about just the practice of medicine in Georgia? On the whole, we are not totally unhappy. This is a ranking that polled physicians across the country, and the numbers at the end recognize where we are at, compared to the other 50 states. So not so bad. So there are some really good things that is going on. So let me mention some of those good things that have happened in Georgia. Thank you, Georgia, for the civil liability reform. Even though I know it wasn't meant for physicians, it definitely impacts us, and many of the organizations, the medical organizations in the state of Georgia, were really proactive on pushing this through, because this limits our liability for malpractice, and hopefully will also put, to a certain extent, a cap on the amount that we have to pay for malpractice. Having been in New York and in other areas where the malpractice rates went up so much that physicians were leaving the states, this is going to be a huge deal, and it's going to have a lot of impact for us. The other thing that Georgia did was the P-TIP program. This is phenomenal. We were the very first state, Georgia was the first state in 2014 to create this program, and what it does is, if I am a community physician and I get a phone call from the medical partnership saying, will you take a medical student? My first inclination is usually like, oh, I love to teach, but how is that going to impact my practice? Because I am not paid to teach, I'm paid to see patients, and my income comes from seeing patients. So when I take a medical student into my practice, my income actually goes down because of the amount of time that I spend with that student. So when you did the study back in the 1990s or so, looking at how much does it cost for a physician to have a student or a resident with them, any kind of a learner, it actually cost the practice at least $400 a month, and that was back in 1990 time. So this is an incredible program where if I am a community physician and Dr. Sumner calls me and says, will you take my student? I know that if I take that student, I will be given a tax credit at the end of the year. So rather than getting paid for taking that student, I can claim a tax deduction kind of on my practice at the end of the year. That's huge. It's only up to about $8,500 a year, but it's something. And not very many states have that. And I would definitely say we need to increase it, improve it, and keep it going. And luckily, it did go through at one of the last renewals. You also, thank you, provided monies to create the UGA School of Medicine. We just went through our accreditation review, and we're hoping that in February, this will continue right along. But because the state said we will provide funds, this is why we're able to create the new UGA School of Medicine, which will add 60 more seats to the number of medical students graduating in the state of Georgia. You've also continued the rural physician tax credit so that if I'm working in a rural area, I can actually take a credit of up to $5,000 every year. That just gives my practice a little bit more incentive and a little bit more economic feasibility. Okay, but those were the good things. We're still in need. You probably all saw this. I practice at St. Mary's as well, and St. Mary's Livonia is closing their OBGYN facility. Many hospitals are closing because they don't have the finances to keep their doors open. If we don't have the hospitals, not only are we causing an economic drain on that community, but where are our learners going to go, right? When St. Mary's Livonia closed their OBGYN program, what happens to the OBGYN practice that's in Livonia? It's going to take those patients an hour to go from Livonia to Athens. Do you know how complicated an OB delivery can be? Do you know sometimes you only have minutes? So not only are we going to increase the hassles with maternal fetal health that we have in Georgia, the problems that we have, but now we have an OBGYN practice that wanted to be in Livonia, and they won't be able to deliver at their local hospital. So you talked a little bit before about travel, and a couple of our students have actually put together a few posters about travel. And I mean, one of the things is when you have to travel, you have increased transportation costs. But for some of us, I traveled here from Athens, I'm not worried about the gas price. But a lot of people are, if they have a car in the first place. And then you have to take time away from family. If you have to take time off of work, that's increased loss of wages. How many of those patients, those OB patients in Livonia who now have to travel an hour to see their OBGYN because that practice is going to close, are going to be able to come as frequently as they need to for their visits? And also, one of the economic drivers in a local community is the physician and the practice that they run. Not only do you get the taxes, or the state of Georgia get the taxes from the monies that I make, but from all of the people that I employ, plus all the people that I keep healthy because they can come see me because I'm close by and I can keep them healthy so they can go back to work. So how do you all provide a pathway to internal medicine? How do you provide this ability for us to continue to practice and study in the state of Georgia? One, okay, we have to have health insurance. We have to have a way for our patients to be able to come and see us. You know, yes, there are free clinics. Yes, there are FQHCs. Yes, there are ways, but it is really difficult for some of my patients to be able to get in. As the ACA subsidies expire and that are scheduled to due at the end of this year, we know we're going to have folks that are just going to say, forget it, it's just not worth it, I don't have the money for this. We know that when the Medicaid rules kind of changed right at the end of COVID, I work in a practice where we have residents, the number of patients we saw went right down. Why? Because the COVID guidelines that said you didn't have to renew your Medicaid every year had changed to every 3 years, but once that went away, all these people who thought they had insurance didn't, and our numbers really decreased. The other is a downcoding in Georgia. This is something that's coming up. It started today. Cigna, if I bill a level 4, which is what most internal medicine physicians bill because there's multiple medical problems with my patients, if I bill a level 4 and it gets sent to Cigna, Cigna will say, nah, we're not going to pay you that. It doesn't matter that all your documentation is right. We're just going to downcode you and bill it and pay you for a level 3. What? I mean, what business can survive if I agree that my sandwich is going to cost you $6 and then you eat your sandwich and say, nah, I'm only going to pay you 3. Come after me for it. Really? Increased funding for medical education. Yes, I greatly appreciate the $50 million, greatly appreciate that the state gives money to our public medical schools, but we still only support, what, 360 plus the 100 and, is it 50 that are at Mercer? 180 a class. But there's still more, and if we want to be able to get our medical students to look like the state of Georgia, we may need to increase the subsidies and the scholarships that they're getting. So definitely increase the funding for scholarships for medical students, as well as fight against the student loan cap of $200,000. The cap that is planning on going to place that will cap medical students plus other professionals of $200,000 at the end of their education. That means it's going to include their pre-med education plus their medical school. What's going to happen is it's not that we're just going to stop and we're going to go, oh, okay, well, just go on for free. We don't need the rest of it. Those students are going to be taking out private loans, which have a much higher interest rate, which I have a medical student that graduated a few years ago. She's currently in residency. She had a couple of kids. They had other things going on. She is in debt to $425,000. She is just completing residency. She will not complete paying off her debt until way after her children are out of college. So she's going to have a really hard time funding them as well. So thank you for this. I want to invite my students and my resident back up, or our student and resident. Just if you have some additional questions, and I know that you all answered some of the things about match, we'd be happy to talk about that as well. We interview medical students for residency, so we can always comment a little bit about those things as well. So any questions or thoughts? Let me ask you both, when you chose where you want to do your clerkship, did you have a choice on which location and what kind of went into that? I mean, I know some of our students have family in Atlanta. Do you want to?
Yeah. So yes, we were given a choice on where we could rotate location-wise, whether that's Athens or we have the regional campus here, just the hospital in Lawrenceville. I know we can go up to Gainesville as well. We're given the choice of where we could go and the order of the rotations that we want, which plays a factor into when you're able to study. Like I chose an elective before this internal medicine rotation to get ahead of the studying. But yeah, there are a lot of external factors that go into where you rotate. A lot of people are able to afford housing in Athens all the way through med school, so they stay there. Other people have family in Atlanta or Gainesville, so they choose that. So yeah, a lot of factors going in.
Yeah, I was definitely an example of that case where I have family who lives in Lawrenceville actually, so this was my top pick. I wanted to come back and not have to renew my lease in Athens, so I was trying to get rotations that were kind of in the Gwinnett area, which didn't necessarily always work out. A lot of my rotations are still in Athens, which is still good because I'm familiar with the area and feel comfortable there. And thankfully, we have a lot of opportunities for AHEC housing, where we get free housing as medical students in areas that are farther away from our home campus.
Do you want to talk a little bit about going into primary care?
Yeah, of course. So like I mentioned before, I'm currently a third-year resident, and I'm on the job market right now, but my primary interest is in primary care. The reason why I chose primary care is because I enjoy like the continuity of care with the patient and being able to follow them through their medical journey. There's tons of chronic conditions that we manage and that I enjoy managing, and the primary goal is to keep patients out of the hospital, and that's something that I'm very passionate about and why I'm excited to go into primary care.
So any questions, any thoughts? Any comments that I can focus on from the last speaker that you want me to focus on?
Where do each of you hope to practice?
So actually, my husband lives in Brunswick, Georgia, so I'm hoping to move down there.
Yay.
And practice there.
I think ideally for me, the Metro Atlanta area, since it's close to family as well, so Lilburn or Lawrenceville.
I'd like to be in North Atlanta, like Roswell area.
30% of physicians come back to where they did their undergraduate medical education. Again, why the increase in funding for undergraduate med ed is really useful. We want them to stay here. If you had gone to, Rush for medical school, chances of you actually coming back and doing residency and living there would be much less. Good. Thank you.
Oh, yes.
I just have a comment. I think it's real important for us to think about, before we do away with taxes in Georgia, just thinking about how all the state taxes help, the state tax credit for physicians that take in residents, the Georgia Heart Program. There's just a lot to consider, whenever we think about that.
And we're grateful. As a state employee, I'm very grateful. All right, thank you.
Thank you.
So members and staff, I want to thank everybody for your presentations this morning. The information has been so helpful. And again, presentations today can be emailed to you. We are going to take a lunch break and move, thank you, Dr. Newton, for staying with us, and we will hear from you this afternoon. Thank you so much. I think everybody's getting a little bit hungry. So we're going to take a short lunch break and return at 1:15. Lunch will be provided through the back door to the right down the hall. So this direction here, and if there's no other items, we stand in recess until 1:15. Thank you so much. Good afternoon. We are ready to get started. LTS Health with David Newton, VP for State Public Sector Health.
Can you hear me okay? All right, so thank you, Madam Chair, for allowing us to come here and talk. So my name is David Newton. I'm joined in the audience with one of my colleagues, Dr. Diane Foley, who's one of our chief medical officers. As Todd mentioned earlier, he's a paramedic, so am I. I've been a paramedic for just over 27 years. I have worked not only in this county, so I used to teach at Gwinnett Tech just down the road, used to teach the paramedic program there. I also worked in public health. So Megan and I were just talking that I used to work for the Department of Public Health prior to COVID and then during COVID, so that was a fun time while we were there. But it's great to be here, and today I'm going to talk about, not EMS, but I'm going to talk about our LTS Health, our Test and Go kiosk that we have. So not going to really go over this. This has already been mentioned a lot in this committee. What I do want to say is we have a shared goal at LTS is to strengthen the reach of the existing providers. So you're going to see a lot about what we can do and all of that. This is not meant to replace anything that's already out there. It is meant to extend those, whether it's an FQHC or whether it's a hospital, a rural hospital. It's meant to extend those, extend that reach with new practical access points. And so I'm going to tell you a story. So we're going to talk about Jim. So Jim is a 52-year-old warehouse worker in rural Georgia. He works long rotating shifts. He hasn't seen the doctor in years, probably a story you've heard before. And so he's been getting tired and he's really thirsty all the time and just kind of run down. And he just thinks that this is just part of growing old until he actually sees a kiosk that is in his community near where he works. And so Jim decides to go up to the kiosk, go check it out. He sees that they have a screening test. And so the screening test is for hemoglobin A1C. And so he gets that kit out. It's a self-collected kit, so he does not have to go into a clinic. He doesn't have to go see a healthcare provider to collect that specimen. He collects it, he puts it back in the bag, he follows all the instructions and sends it in. When he gets his results, no surprise, his hemoglobin A1C is high. And so he actually gets connected to an FQHC or a rural hospital, but he gets connected to care in his community where he goes in, he gets to talk with a physician about what's going on with him, all of his previous symptoms, and really gets to help. He now understands how to treat and how to manage his diabetes. And all of this came from him being able to access that. And so I picked one of the FQHCs. This is in Ashburn, Georgia, where he got to go in, he got to get seen, and he got, again, his medication. And then after that, right, he was able to manage his care. He was able to, get repeat hemoglobin A1Cs, whether that was from the kiosk or a mail order program that sends it directly to his house, where he doesn't have to give up his shift. He doesn't have to give up, that time during the day when he's working to go see the doctor. He can actually do it on a schedule that's more convenient for them. And again, this is just kind of a story of one of the things that is possible when we have the increased access that we're actually talking about here. And so this is our kiosk. You might have seen this before because we actually had a contract during COVID time with the Department of Public Health, and at the height of that, we actually had 80 kiosks in the state. Those were there for COVID and flu testing, but that's just one component of what we do as the respiratory. What we're talking about here with not only the kiosk, but also with mail order program, because there's going to be some patients who can't physically get to a kiosk. They're homebound. And so having the two of them together really does allow patients to get that care and that testing, that screening close to where they live, close to where they work. And so, as I mentioned earlier, this is about not replacing any provider that's already there. This is about enhancing their reach, expanding that reach. And so it actually acts as a force multiplier for them, right? For them to be able to get to the patients who would not otherwise have gone in. I have plenty of family members who will sometimes call me up because they know I'm a paramedic, and they'll literally start telling me all of their signs and symptoms, like, go to the doctor, please, I'm not here. And even, in my family, right, I've got people who will not go, and if it was more, I don't want to have to drive there, right? And so having it more convenient for them where they can get that screening that is necessary is much more helpful for them. It's affordable, it's scalable, and again, it's 24/7. If you've got someone who who works the late shift and they can't get to a doctor, this is open at midnight, right? So this is something that they can go and they can access. And this can be anywhere, right? This could be at a college campus, right? We've actually got a lot of these at college campuses in the country. So this is what it looks like. As I've mentioned, no staffing is required for this. This can go indoors or outdoors. So this is not bound by the hours of a building. This can be outside, this can be in the community. And there's really minimal site requirements that are necessary for this. We want a level piece of concrete usually that's accessible so that a wheelchair can get around it, and we need power. It's a standard outlet, it's not a 220. So it's very easy for us to install one of these and have that available in the community. And that's what we've seen, again, not only with DPH, but also with our other customers across the country. As of today, we have 118 kiosks installed in 11 states. Most of them are with health departments, but we also have some with colleges and universities. We've got also got some on tribal lands. And it's turnkey. This is not something that we're saying, all right, we're going to put at your hospital and now you have to go stock it. You have to, watch the expiration dates of everything in there. No, this is what we handle for them. So it's really a turnkey, and that's actually why they like our service, is because they don't have to take one of their nurses' time to go and stock it or to go maintain it, right? That's for those higher touch activities of the patient care and the patient follow-up. So what can you do with this? And one thing that COVID taught us is people want to get tested when they want to get tested on their own schedule, and they want to do it themselves. A lot of patients do. Respiratory testing is easy. That's a nasal swab, very easy. That's COVID, flu, RSV. STI testing, right? There's so many tests that you can do that are self-collected, validated STI test kits. So you're talking gonorrhea, chlamydia, trich, HIV, syphilis, Hep B, Hep C. And then now wellness testing, right? So cholesterol screens, diabetes, hemoglobin A1C screening, kidney health screening, so creatinine and EGFR, right? You can do hormone levels. You can do full-on prep testing, self-collected. And so there's been a lot of studies out there that show that patients who are doing self-collected and get it from a machine like this actually increase their testing rates because of that reduced stigma of having, they don't want to go have that first conversation with a clinician to see about getting that. You've probably seen ones that give out naloxone, right? So for overdose reversal. So one machine can do all of this, right? We even have where you can give out glucometers. So all of those tools that are necessary, you can have that in their hygiene supplies, for the unhoused, right? So anything that you can think of, I always say if it's legal and it can fit. So we can't put a CPAP device in there, but we can put pretty much anything else in there, again, as long as it's legal in that state. And all the lab testing that we do, it doesn't have to be our lab. It can be that hospital's lab, that FQHC's lab, as long as they have validated self-collected test kits that don't have to be observed by a clinician, because that's what right? This is something that they're getting at 4 o'clock in the morning. It's got to be something that they can do on their own without a clinician having to, actually watch them do that test. So this is really about having care where you live, work, and play. So beyond the brick and mortars, right? Again, expanding that reach and putting it where people are. So whether it's on a farm, it's at a work site, a school, library, community center, we have them, we've had them, at a lot of times at health departments or like I said, at colleges. We have one customer that their health director said, and this is in Alabama, and he said, I do not want them at health departments. I want them out in the community. So they put one at a bar and they put one outside of a community pharmacy. And so, they have those community partners there. And so they can go anywhere, again, power and level concrete. That's all we need. And if you think about this for employers as well, is that if the patient is staying healthy because they were able to get a test, they were able to get screened for something earlier than they would have, then that person stays healthy and then they stay in that workforce there. So it's really about having that benefit for the employers as well. And it's a flexible infrastructure. So when cold and flu season hits, we can put new test kits in there or more test kits in there for cold, for flu and COVID and RSV. And then when that's not necessary, we can, dial that back. But if there's another pandemic, which I keep saying, as long as that's after I retire, because that was a lot during COVID. But if there is another pandemic, you already have this in your community as a 24/7 testing site, regardless of the population density that you have. You now have this available 24/7 for your community. So how do we make this a reality in Georgia? So we can build on Georgia's experience. Again, this was during COVID. We had 80 of them in Georgia, but also build on the experience of other states. What you see on the heat map here is actually where we had all of the kiosks in Georgia, and then the heat map is showing how many dispenses, right? So how many COVID test kits were actually given out in those areas there. Partnering with existing providers. Again, this is not meant to be another provider in an area, especially for the wellness testing. This is meant to be something that can extend their reach. So really partnering with them, whether it's putting it at their site or putting it in an area that doesn't have a brick and mortar site there. So practical funding pathways, what we've seen other states do, or cities, counties, as some of our customers, is either state dollars, county dollars, right? So traditional funding streams, but also they have their opioid dollars that they will use for this because the infrastructure can be purchased with that, and then they have the other items that they can add. Other funding streams that they've had include obviously different federal funding streams, grants and stuff that can pay for like STI testing and other things. But also one thing that a lot of them are looking at now is the Rural Health Transformation Program, which I'm sure is not new, right? This is something that's been going on. It's the $10 billion over 5 years, that the application to CMS is actually due by November 5th. And so this is something that DCH is working on in Georgia, and we've submitted input on that as well as to 40-something other states right now, because all of the states are trying to figure out, well, how are they going to do this RHTP program? And so this is a potential recommendation, is that if this is of interest, that the state could include this in their application to CMS for that. Because when you look at the cost of this, if you avoided one hospital readmission, or if you avoided one emergency room admission, right? Which I know that they depend on obviously patients coming to see them, but for the patient, right, if they can get something seen quicker, it is more cost effective for them to have that up front, right, that testing, than to have to go to an emergency room visit. And so that's, again, just a possible recommendation, is that this, a program like this could be incorporated, again, integrated with the current existing FQHCs and hospitals in there. And that's all I've got. So Dr. Foley, or I will take questions.
Yes.
So this is like a vending machine, and it has all the different products, and you go up and you choose G1 or whatever. And
it's a touch screen, but yes, you would go up and choose those items. But then we also do all the servicing of it too, and the testing, right? So we actually have the lab that can do all of that, so that they can come get the test, they can go take their test and get it. But we also have the mail order program that we've seen successful in some other areas. So like Los Angeles County is doing this, where they have some homebound patients, and they set it up that, well, you can't get to a kiosk, so we're going to have it shipped to your house.
And it's tied to some sort of communication that when something gets low, y'all are notified to go restock.
We watch it for stock levels. We watch it for temperature, because a lot of the items that go in there, like naloxone, are temperature sensitive. So we heat and cool on the inside of it. It's got a battery backup. So if the power in the building goes out temporarily, the battery backup kicks in. If it's a long time power outage, we're going to come and retrieve all the things that are temperature sensitive and then return it once the power is back. Dr. Foley.
I think that's different about this than a vending machine a little bit, is that
we have the ability to be able to use algorithms to help patients decide what they need. So it's not like walking up and looking, oh wow, what do I want? It's being able to ask questions around what their risk factors are, particularly the STI testing. So then we lead them through an algorithm to what testing they should have done. In addition, they're also given specific information local to whatever that kiosk is of where they can go for follow-up care. Your closest FQHC is here. Your private practices are here. So all of that is included in the information they get to know where they can go to have follow-up. So there's a lot of AI-driven information specific to wherever that kiosk is placed to direct them in that way.
And you've seen some of the kiosks have different designs on them. You can actually brand it with an FQHC's information, or brand it with a hospital's information.
Follow-up, how do y'all get paid for your service?
So whoever we contract with, again, most of our contracts today are with health departments or the colleges and universities, and again, some tribal ones. So we get paid through whatever that is. Unfortunately, insurance, like for self-collected test kits, No insurance that we know of pays for a self-collected test kit that was not part of a clinician visit. So there is, of course, a downside to that, but that is how we get paid usually, is through that.
Thank you.
Representative Osteen.
But if you have a clinician visit and they want this test ordered, I'm trying to figure out how this works.
So like if the patient went into an FQHC, saw the clinician said you need a test, go pick it up at the kiosk, I believe the physician, and Diane, correct me if I'm wrong, the physician would bill for that as part of their services.
Okay, so it works that way, but it doesn't work in reverse.
Correct. If someone just, during COVID it did, but only for COVID, right? So that was one of the things that was in that time, was that it had to pay for that. But for right now, we don't know of any insurance that pays for it. If I just choose to go get, a cholesterol screening today without going to my doctor first, then no insurance pays for that unless it's part of their wellness program.
So I could just pay for it out of pocket. Is it at a reduced rate than what I would pay at the hospital or through some testing?
So it depends on what test you're getting, but yeah, I mean, it's going to be pretty comparable to what you could get online, for a similar test. Because there's tons of ones out there. This just happens to be where I can physically go and get it whenever I need to get it without having to wait for it. Because especially with STI testing, some of the stuff we've noted is that patients sometimes do not want it mailed to their home for certain reasons, and so they want to be able to go get it at 4 o'clock in the morning on their own and do the test, and then they can get their results electronically. And then but get connected to care afterwards.
Do you know like how many Georgians use this now?
So right now in Georgia, we only have one. So we actually contracted with Georgia Southern, by the way, with IHLA, the Institute for Health Logistics. So they're going to be putting one in Statesboro, and they're doing research on that one. But the ones that we had under COVID for Georgia DPH, when the federal funding ended, we did have to remove those. But we have 118 in other areas of the country, 11 states right now. But in Georgia, we had 14,000 plus test kits dispensed in Georgia during the COVID time. Yeah. But again, the only thing that they had in there because of the funding stream was just COVID and flu testing.
Any other questions? Thank you. Thank you so much.
Next, we have the Department of Public Health.
All right. Good afternoon, everyone. I feel like I'm too short hiding back here. I'm Megan Andrews. I am the Assistant Commissioner for Policy at the Georgia Department of Public Health. I spoke to you all, I think at your first meeting, but I'm here to talk about the EMS system in Georgia. DPH is the entity that's charged with regulating EMS, so I wanted to give you guys some background and just some foundational knowledge because you seemed very interested in this topic. So EMS services are in statute. I have both the statutory reference as well as our rules and regulations if you want to look up either one of those items, as well as our Office of EMS and Trauma's mission. So within statute, DPH is charged with the responsibility of managing the EMS system, and the reason for that is stated in statute that the goal is to create an EMS system that's coordinated, orderly, economical, and without unnecessary duplication of services and facilities, which leads us to the zoning process that Georgia follows in order to address those concerns. Anytime that the EMS zoning decisions are made, they are need to be based on 3 factors: economy, efficiency, and benefit to public welfare. I bolded those because you're going to see me refer to those terms several times throughout this presentation, and I apologize, Representative Osteen, you're going to hear this presentation again. But maybe you have some questions after the last one. So moving on, what does our Office of EMS do? So I have 3 buckets here for for you all. The first is we license EMS agencies. So these are the ambulances you see on the roads, the companies themselves. So we inspect those vehicles, make sure they're up to standards. We also do EMS provider licenses. So just like nurses get licensed, physicians get licensed, DPH is the entity that's responsible for issuing licenses to the various EMTs, paramedics. These are all the different provider types that we license. And then lastly, we do hospital designations. So if a hospital wants to be a trauma center, a cardiac center, we do all of the review of applications and ensure that they meet the standards to be that level of care provider and designate them accordingly. So within EMS, there are different service delivery models. Typically, it's going to be ground ambulance. You'll have one of three. A government-run EMS agency, so that's run by either the county government or the fire department. There's also private EMS services, so that are just private companies that run an EMS service. And then there's hospital-based ones, which the EMS is associated with the local hospital. And when we award a zone to a provider, there's really two different mechanisms of providing the service. Either the awardee of the zone can be a direct service provider, so whoever wins the zone, they are the ones providing the service and responding to 911 calls. Another structure that is in place is whoever is awarded the zone can contract with another entity to provide the service within the county. An example of that is in DeKalb County. DeKalb Fire and EMS holds the EMS license, but they contract with AMR to run 911 response services within the county. So, Georgia's EMS system, we're responsible to ensure that an EMS agency is responding to 911 calls in every emergency response zone in Georgia. There are 159 counties in Georgia and 175 emergency response zones. For the most part, the zones are the counties themselves, the county borders. There are a few exceptions that I have listed here. There are a couple counties that have more than one zone. I have them all listed as well as the number of zones that are within those counties. And this could be for a variety of reasons. It may be the municipality in that zone wants to run their own service, so they partner with the county, and there's two EMS agencies doing zone response. Or it could be there's a population, for example, Fulton has 5 zones. So it could vary. It doesn't have to be based on county borders, but for the most part, that's how it looks. And we do have 2 counties that share one zone, Oconee and Clark, and they have 2 designated zone providers that work together collaboratively to cross county lines and provide services together. So the zoning process is conducted by these regional EMS advisory councils. If you read the statute, the statute refers to local coordinating entities. What that refers to are these councils. So there's 10 of them around the state, and I have a map here showing you where they're located. And what they do is they evaluate the EMS services within their region and make recommendations as far as zoning goes about how emergency calls should be distributed among ambulance providers in their region. They also promote training programs for personnel that are involved with the delivery of EMS. They also, it's a public forum, so these meetings are open to the public if anyone wants to go and listen in. And I also have Leo put in your folders, I printed out your zone plan for your part of the state if you're interested in seeing it, as well as a list of all the zone providers throughout the state. And these regional councils recommend to the Commissioner of DPH what the 911 response should look like within each of the zones in their region. And ultimately, the Commissioner of DPH makes that final determination. We are starting to have the REMSACs conduct quarterly review of key performance measures for all of the EMS agencies within their region. So they'll get quarterly reports of data runs that we pull and look at performance to identify any issues early on if they aren't receiving complaints. This is another way that we're hoping to address any challenges. So who sits on these REMSACs? This is a list of the membership. It has a variety of members. County commissioners make appointments. There's representatives from EMS education, the various agency types, various ownership types. So I'm not going to read through them, but that's the list of who sits on these. Here are the REMSAC's responsibilities, and the decisions of these REMSACs and the zoning plan that they establish has to be based on these three things, and this is in statute that I referenced before. So how does zoning work? A REMSAC can receive a request or a complaint regarding an emergency response zone. It can be from anyone. It doesn't need to be from a hospital or a government official. It could be from a member of the public. So these are the steps that the committee goes through when they receive a complaint. First, the REMSAC has to determine if that complaint is related to economy, efficiency, and benefit to public welfare. I'm sure as legislators, you all get complaints all the time. We have to make sure that the complaint is relevant to the zoning itself. It's not, I don't like that guy's shirt, or I don't like what their logo looks like. It has to be a legitimate complaint. If it is, then they move on to step 2, which is they conduct a detailed examination and assessment of the key performance measures of that zone. I have a few of the key performance measures listed here, just 2 examples. There's several. I wasn't going to bore you with all of them, but these are some of the things that the committee will look at as far as what's considered a key performance measure. The percentage of STEMI alert patients that are transported to the correct hospital, the percentage of stroke alert events in which the on-scene time is less than or equal to 15 minutes. Those are goals of all of the EMS agencies in the state. So after that key performance assessment is done by that regional council, they ask a few questions. Has there been a significant decline in the performance of that EMS provider, or is there an opportunity for significant improvement? If the answer is yes to that, then the next question is, can that existing provider address those concerns? Do they have a plan to improve service delivery? If so, then they're provided an opportunity for improvement. Generally, that is about 6 months, and then the committee meets again, and they look at all of that data again to see has performance improved over that time. If it hasn't improved, then they consider opening zone. They can vote to open zone at that point. The zoning process looks very similar to a DOAS competitive procurement process. It's a bidding process, and there's scoring rubrics and all of that. So if you're familiar with that, that's typically how it works. So when a zone is opened, DPH gives notice to all of the licensed ground ambulance services in the state. We tell them the dates for the zoning process, and then we also provide a lot of statistical data about the zone. For example, things like call volume, times of day where there's peak call volume, payer mix, a lot of information that those EMS services are going to need in order to write a bid that is responsive to the needs of that community. After that, all the zone proposal applications are received, and the scoring rubric is given to the zoning committee. Typically, that full REMSAC, it's quite large. They don't review every application themselves. They appoint a subcommittee who really dives into the data and the details of all of the applications. They do scoring and make a recommendation to the full REMSAC. That full REMSAC then votes on the recommendation, and then it's sent to the DPH commissioner for final review and approval. Some things to know about EMS zoning, and these are just issues that have come up over the years, so I wanted to make sure I hit on them. A zoning plan can also include changing the zone itself. So, for example, if a municipality during a zoning process wants to run their own zone, they can partner with the local county government or even a private provider and say, hey, let's submit a proposal together. I'll propose to run my own municipal zone, and then you can run the rest of the county, like the full zone. So it could split a zone in two. It could be a proposal to combine zones. So changing the lines of the zones themselves do occur through this process. Zone proposals from providers may also include a requirement that the county government subsidize the service. Like I said previously, we provide a lot of data in this bidding process so that we can get bids that are based on the actual needs of the community. And part of that, when we look at payer mix, is there may be uncompensated care in significant numbers that an EMS service needs a subsidy in order to operate for the foreseeable future. So there are many zones that require a subsidy from the county. And if that's required, it is included in their zone proposal, and it's considered through the zoning process in making that determination. That's the economical factor there that we look at. Let's see, that's it there. Some issues that we've been seeing across Georgia, there's been increased wall times at hospitals. I'm sure you have all heard this term at some point, but that's essentially when an EMS service brings a patient to a hospital, they can't just drop the patient off and say, see ya, good luck. They have to actually transfer care of that patient to the hospital staff. So there's been challenges with that, especially during COVID and post-COVID. We've seen this be a recurring issue. Workforce shortages certainly play into that. There needs to be staff at the hospital to take over the patient and the file. We've also seen an increase in 911 requests, sometimes not for emergencies. You know, it may be someone that just doesn't have family around to transport them to the hospital, so they call 911, and if they end up in an ambulance, that may lead to wall time issues too, because they're not prioritized as, you know, top priority to get a bed if there's someone, you know, having a heart attack in the waiting room. So that could lead to issues too. Reimbursement has been challenging. There's, you know, the cost to provide the service doesn't always match what is actually being reimbursed by insurance companies. The workforce shortages that I mentioned, as well as interfacility transports, are an issue and have been an issue. If an interfacility transport is an emergency, meaning that they would call 911, then they are treated as a 911 call. This whole zoning process I'm talking about is for 911 response, emergency response. If it's a non-emergency transport, they are not prioritized the same level as an emergency because ambulances need to be available to come pick patients up. So that's an ongoing challenge, especially when we're in rural Georgia and you have to travel long distances, sometimes hours away to get a patient to the right level of care. That ambulance is then out of the county and not responding to 911 calls. So that's another challenge that we've been working on. But that is, tried going fast to keep you guys on time, but I'm available for questions if there are any, or if you have any later too, you can reach out to me.
Representative?
Yes, please. On the reimbursement, if you could back up one slide right there where it says with the cost to provide the service, so they're running at a loss, is that what that means?
They could be, depending on, and I'd rely on the EMS Association to give you more information on that, but from what we're told, the cost to run an EMS service is pretty expensive as far as the equipment, the 24/7 staffing. You know, we quoted a pilot project a few years ago and provided a rough estimate of about $1 million a year to run one ambulance. So the reimbursement that's received doesn't cover completely the cost to run an EMS service. And the only paid if there's a transport. We have been working with DCH, and there's a few codes that have been opened up for Medicaid reimbursement to treat patients without transporting them, but there's some parameters around that, and utilization doesn't seem to be what we would hope it would be. So that's something else we're working on, is trying to promote, you know, if someone has a sprained ankle, can we patch them up at home and not need to transport them, and make sure the EMS service gets reimbursed accordingly to provide that care. So those are all things we've been working on.
It's pretty tough for a business to run when they can't get their expenses reimbursed. I mean, to stay in business, any business.
Thank you so much.
Thank you.
Next, we have Georgia Watch, Natasha Taylor, MA Deputy Director.
Oh, thank you. Thank you. Good afternoon, Madam Chair, members of the committee. I am Natasha Taylor, Deputy Director of Georgia Watch. We are a statewide consumer advocacy organization. We are focused on the issues that impact the quality of life for consumers across Georgia. And today I'm going to talk to you really about why internal medicine and access to it matters from a consumer standpoint. As you already know, internal medicine is the first line of defense when it comes to managing chronic diseases. Without internal medicine, people delay care, conditions worsen, and small issues become emergencies. Internal medicine is the cornerstone of chronic disease management and prevention, and investing in access reduces uncompensated care, ER use, and medical debt. At Georgia Watch, we have a toll-free consumer hotline where we often hear about the barriers that people face to accessing internal medicine. 3 of those being insurance coverage or lack thereof, fear of medical debt, and workforce shortages. When it comes to insurance coverage, for many of our consumers that call in, a doctor's visit seems unaffordable, so they don't go at all. Delaying care until it's critical leads to ER visits, and many of our consumers delay care because of medical debt, which I'll dig into a little bit deeper on the next slide. And then workforce shortages, so limited access to providers and resources exacerbate illness. So why does this matter? With affordable comprehensive coverage, people are more likely to access an internal medicine provider early and prevent themselves from going to the ER. As you've all heard from many before, the tax credits are set to expire, meaning many will drop coverage. Premiums are expected to jump over 75% for your average consumer, causing Georgian staff to choose between healthcare coverage, rent, or groceries. The Medical Association of Georgia told Congress in a recent report that losing subsidies would hit older adults, rural residents, and small business owners the hardest. A fellow colleague of mine who's a nonprofit director for a local nonprofit said that she, with the anticipated increases in her cost of coverage, she's gonna have to choose between healthcare coverage and paying her mortgage. So she's more likely to just drop her coverage for her family, which includes her husband and 2 small children. So that's kind of the situation that people are facing. When we talk about medical debt, we know that medical debt discourages people from seeking preventative or follow-up care. We have a lot of consumers that call into our hotline complaining about medical debt. We have seniors that call in saying that they have a debt with a provider and they're scared to go back to the doctor because they know that they owe a bill. We know that delays lead to higher cost in care, more unpaid medical bills. So again, those seniors that need that care, that need to go to the doctor, delay, and then always end up at the ER, which is a way higher bill than if they had just went to their internal medicine provider. So we would like to try to find ways to kind of mitigate that medical debt. When it comes to workforce shortages, we know that workforce shortages, as has already been said before, limit timely access to internal medicine providers. We know that community health workers, Georgia Watch leads the Community Health Worker Advocacy Coalition, can help with these shortages. They help by extending the capacity of internal medicine providers. They can help patients navigate resources, getting access to the internal medicine provider. Sometimes people just don't have transportation or they need help with childcare. That's where community health workers can help fill those gaps, particularly in our rural areas and our underserved parts of the state. So our recommended solutions, obviously federal extension of those tax credits, but also exploring maybe the state covering some of those costs to help keep healthcare affordable for our consumers. Strengthen hospital financial assistance screening, again, so that people know that there are payment plans available to them if possible. Increase charitable care spending on behalf of our nonprofit hospitals, investing in programs that can keep people out of the ER, that can keep people healthy, teach them how to manage those chronic conditions. Programs to eliminate or manage medical debt. I myself was a full-time student, working full-time, had medical debt, and that kept me from buying my first home. That often kept me from getting approved for apartments. I didn't go to the doctor asking to take out a loan. I went to the doctor sick. And that hindered me for many, many years while being a student. And I was working full-time in management. You would think I could have afforded it, but I often had to choose between paying my rent and paying my medical bills. And then CHW integration through certification and reimbursement. Thank you to the House for passing CHW certification last year. It is in the Senate as we go into the next legislative session. So we're looking for certification to be passed in the next legislative session, but that would create a state recognized certification for community health workers to streamline the skills that they all have across the state, and also hopefully leading to reimbursement for community health workers. Right now they're grant funded, so when that grant funding runs out, communities lose that trusted resource. So we're looking and working with DCH to explore avenues for reimbursement of community health workers beyond certification. And I'm open for any questions.
Rodham.
I enjoyed it. Medicaid is not going to be expanded in the state of Georgia, not for a good while.
Mm-hmm.
So what we have is called pathways to coverage. How is your organization helping people? You know, I noticed your second bullet point was getting hospitals to increase their screening for the working poor. Are you guys doing anything about that? Are you helping get that out there? We've only got 8,000 people out of 250,000 that have signed up for it.
Yes.
And I'd like to see it utilized.
Absolutely, and we 100% agree, both with Pathways and Georgia Access. That's where we are utilizing our community health workers and our navigators to push out information, because like you said, there are a lot of people that don't even know that we have a state-based marketplace. There are a lot of people that don't know about Pathways to Coverage. So there are resources that currently exist in our state that consumers don't know about. So that is, again, why we kind of push that community health worker aspect to make sure that information is getting to communities, and not just getting there, but it's coming from a trusted resource. Because as you know, if you get a mailer in the mail, you might read that and go, I'm not signing up for that, that's not for me. So having a trusted resource deliver that message is really vital.
Are you guys delivering that message?
Yes, through community health workers, yes. So we lead the statewide consumer community health worker advocacy coalition, and we also work with partners with the CHW network. So quarterly we have meetings with CHWs from across the state to give them this information to make sure that they're getting it out to communities. But more resources are needed to spread that message further.
Okay, thank you so much.
Thank you.
Let's see.
So next we have the United Advanced Practice Nurses of Georgia, Robin Pinkerton, and she is the Director of Government Relations.
And we have more slides too. Why are they not showing up? Okay. I'll go ahead and get started since we're having a little bit of a technical difficulty. I'm Robin Pinchton. I'm a family nurse practitioner. I'm Director of Government Relations for UAPRN, which stands for United Advanced Practice Registered Nurses of Georgia. As you can see, we brought a group to present to y'all because nurse practitioners, we have a lot to say, and we think we can be part of the solution to our current healthcare crisis. So I really need my slides, but so to start, do you want to go first? Okay.
Well, I'm just going to watch while we work on the technical difficulties. I just want to thank the...
Go to the mic. Well, I guess I can start. I don't have any slides.
Hi, I'm Gail Mackey. I'm the Executive Director of the Licensed Professional Counselors Association. We cover the entire state of Georgia as a nonprofit. We have about 9,000 members. One thing that we're finding that is difficulty is that nowhere in the United States is there a mental health counseling track. There's a social worker track, a psychologist track. They hear about it in high school. They go to the bachelor's level. They go to the master's level. They get licensed, and then some go on for the PhD programs. There is no track in the whole United States for a mental health professional. I have a 22-year-old I hired in the office. I love her, full of energy. It took her 2 years to find a master's degree in clinical mental health to get licensed here in Georgia under the Secretary of State, the Georgia Composite Board of Professional Counselors, Social Workers, and Marriage and Family Therapists. My promotion here today is I would love to see Georgia be the first in the whole United States to create a bachelor's level of mental health counseling, right? So we think about Statesboro, think about the small high schools. If that person got out of high school and went to their bachelor's level in mental health counseling, then you're going to move them to the track, right? Because a lot of the master's levels have gone online, but they're going to stay in their community. So I'm going to step back because I know they want to get started, but that's my first pitch, and then I hope that if there's time left, I have 2 other quick items to talk about you, but I'd like to see Georgia as number 1.
Okay, great, we're on track now. We got our slides, yay. So I'd like to start with just introducing the practice of what a nurse practitioner is and what we do. This slide is prepared by American Academy of Nurse Practitioners. You'll be hearing a lot about them today. That's our mother organization of UAPRN, if you will. So nurse practitioners are the fastest growing providers for primary care in the country. We have done over nearly 1 billion visits in 2024. 80% of our visits are primary care. Almost 70% of us are certified in primary care as a family nurse practitioner. So this map is very important. You're going to hear a lot about this map. This map is prepared by AANP. This is explaining practice restrictions and what the state of the state is throughout the country. Green means full practice authority. What does full practice authority mean? It means that we can practice to the full scope of our education. That's to the full scope of our education. We are not expanding scope, and that's very important for me to get across. We are not wanting to expand our scope. As you can see, we have 30 states plus the District of Columbia. Wisconsin just turned green this year in July. There are several states that are really progressing with a lot of legislation to become FPA. We have great legislation going on right now in Pennsylvania, South Carolina, and Mississippi. What does yellow mean? Yellow means restricted. Restricted means that they have some barriers to practice, but they can't fully practice independently. So let me backtrack. What does full practice authority really mean? It means we can practice without a collaborative practice agreement with a physician. We can prescribe all medicines, including Schedule IIs, and we can do those procedures that we are trained to do. Red means restricted. It means we have a very restricted collaborative practice agreement, and that is where Georgia lies. We're restricted because we have to be delegated per our collaborative practice agreement. We have to be delegated for everything that we do per law. Now, this map, you're going to hear a lot about the rural health transformation with the big, beautiful bill that came out, the $50 billion grant that's going to be distributed to states, and there's a scorecard that comes with it. AANP worked with Medicare, and they used this map for the AANP, or for the nurse practitioner scorecard, the scoring for this. So we're going to talk more about this map in a little bit. So let's talk about one of the restrictions that we have in Georgia, and that is the Schedule II Controlled Substance Authority. So most states except Oklahoma, Missouri, Arkansas, and Georgia are restricted with our prescriptive authority, with what we can write prescriptions for. 2 years ago, we did pass a bill, our Schedule II bill. It took several years to pass. It allows nurse practitioners and PAs to write for a limited emergency 5-day supply of Schedule II hydrocodone products only. So the issue we're having right now is implementation. This bill was passed 2 years ago. It's still not implemented in Georgia. In Georgia. This is Georgia specific. So that's a huge barrier for us. So we have 3 bills right now that are not implemented. That includes our death certificate, which is about done. Our death certificate, PAs and NPs can sign death certificates. There's an education requirement. We worked with Dr. Geller at the GBI to come up with that education requirement. She did a great job. The Board of Medicine approved it, but they've not posted it on their website yet. So there's only 3 people that have access to that training, myself, Dr. Geller, and the funeral home directors. So we can't disseminate that education piece as a requirement to get nurse practitioners and PAs to be able to sign the backlog of death certificates. That's a huge issue. The third that we passed this year is a guardianship bill. Nurse practitioners, PAs, and licensed professional counselors can now assign guardianship. But that's going to take some training to go through it. And the licensed professional counselors have a great training program. It's about $1,500 to go through. And for each guardian assessment, I think we're going to get reimbursed maybe about $200 for. So there's a backlog of that too. The probate court judges actually came to us with that bill because there's such a backlog of assigning guardianship. Okay, just some details about the Nurse Practice Act here in Georgia. Again, we're very restricted. We would like to see some changes made through that. One issue we're currently having right now is with the Board of Medicine. And Representative Zine, I see you're taking pictures. I have copies of things in your packet that is on your table or in front of you, on your desk in front of you. We have slides. We also have Senate Bill 131 that was authored by Senator Hodges. It's for the nurse
workforce data collection, and we're going to talk about that in a couple minutes. So the Board of Medicine, they were on paper for our collaborative practice agreements. Collaborative practice agreement is the agreement that we hold with the physician who is delegating what we can do. It used to be paper, and it was very antiquated. And the Board of Medicine, as our professions grew, could not keep up with the volume. And they were up to 12 to 24 months behind on authorizing these. And Juliana and I have been in several study committees over the past 3 years trying to improve this process. So they finally came into the 21st century and they went to electronic. But when they did that, they didn't tell anybody what they were doing. They did it overnight, and there was a lot of issues, and there's still a lot of issues. Right now, the biggest issue we have is a rule from the Board of Medicine that states the physician shall initiate the collaborative practice agreement via the ThoughtSpan online program. So that's very difficult to do. The nurse practitioner has no access to it until after it's started by the physician. A lot of the physicians are confused. They don't know how to fill these out. A lot of the large hospital systems, it's very cumbersome to them because credentialers usually will start the process. So what's happening is the physician is handing out their password and login credentials to people, nurse practitioners, credentialers, to do this for them. So other people have access to our nurse practitioners' personal data and the physician's personal information. The other thing that they're having with that too is that it's a credit card payment, and a lot of hospitals don't use a credit card to pay for hundreds of collaborative practice agreements that they're trying to process. So we're working on a rule change. We're working with Emory and several other hospital systems to suggest a rule change to make that a little bit easier on everybody. Okay, again, here's a supervisory agreements or collaborative practice agreements. To be full practice authority in a state, you do not have to have a collaborative practice agreement on file. So, let me make sure I covered everything here. Okay. The other thing I forgot to mention is collaborative practice agreements. They're very expensive, and the Convenient Care Clinic Association, they reached out to Juliana and I a couple years ago because if you see these little, the CVS Minute clinics, the little clinics, they're not staffed with physicians, but they have a medical director. But here in Georgia, they have to have a collaborative practice agreement on file. Now, since we just passed legislation 2 years ago, one doc can have up to 8 NP or PA, any mix to their license. They need one doc for every 8 NPs. So that's a lot of docs they have to have contracts with, and it's very expensive. Personally, in my practice, I pay a collaborative, for 4 NPs, we pay $50,000 a year for a collaborative practice agreement. So you can see in rural Georgia, if an NP is trying to have a practice, it's pretty cumbersome cost-wise. The other issue is that we cannot directly pay or employ a physician. We have to use a third party. So Senator Williams referred a NP who moved here from Virginia. She had a very successful practice in Virginia, independent state. She wanted to be closer to her mom and dad in Milledgeville. So she started the practice here in April. She'd gotten hold with Dr. Williams, or Senator Williams. She called me and I said to her, well, how are you doing your physician arrangement? She was unaware that she could not pay a physician. So she had to stop her practice, find out a way to find a physician and do it legally. So that's the problem with being a really restricted state. You know, when you come in from out of other states that are full practice, you don't know all the nuances of what you can and cannot do, and you're doing things potentially illegally that you don't even know about. So that's an issue. Okay, so we're going to talk a lot about workforce data. Dr. Sumners, when we met last meeting, you asked about our nurse practitioner data. So Dr. Agopian is going to talk about that in a minute. But before she goes into that, there are a couple APRN specialties, right? Back when I went to school 30 years ago, you were only a family nurse practitioner, a pediatric nurse practitioner, or a midwife. That has changed. So you can be an acute adult gerontological nurse practitioner. You can be a adult gerontological primary care nurse practitioner. You can be a family nurse practitioner. You can be a psychiatric mental health nurse practitioner and a pediatric nurse practitioner. Now I'm going to talk about the psychiatric nurse practitioners in just a second, or I'm sorry, just briefly for a minute. The problem we're having with our Schedule II limitation of only doing hydrocodone products is that we can't do stimulants. So what we're seeing in a lot of nurse practitioners who have contracts with the foster care system, they deal with a lot of children, there's a backlog of psychiatrists, availability of psychiatrists to order stimulants, and we can't do that. So a lot of nurse practitioners saying that the foster parents, they're begging for the stimulants. They can't work. They're being called away from work because a child is disruptive in school. And so they don't want to foster those children if they can't get their stimulants. So that's something that needs to be addressed too. And we would love to expand and have legislation to expand that. Okay. All right. So do we need to hurry up? Oh, okay. So we're gonna tell two stories. We're gonna have Lisa Johnson, her slides are next. Back to the rural health care program quickly. So the scorecard. There's a scorecard for nurse practitioners. That's all I really know about. I don't know the full explanation of the scorecard itself. I can just speak to the APRN portion. And those states, remember the map I first showed you? Medicare follow that map. If you're green, you get 100 points on your scorecard, which means more money to the state for your grant. If you're yellow, you get 50 points for your scorecard. If you're red, you get no points, and that's us. Now, if you're showing that you have some legislation that might positively remove barriers, they will consider giving you some points the following year. If that legislation does not pass, you lose those points. So this is why it's so important that we start removing our barriers. We do have House Bill 54 that is up in January. It's sitting, it didn't make the deadline at the end of the session. It's to allow nurse practitioners and PAs to approve home health certifications. So hopefully that'll pass and it'll be one more barrier that will be removed, we hope. Okay, so Lisa Johnson, I'll let you take it.
Thank you to the committee. My name is Lisa Johnson. I'm a family nurse practitioner. I work in, I tried to highlight it, North Georgia. I work with hospice and palliative care. I also do 2 days a week at a family practice clinic. The state map here, we have 159 counties total, and 120 are designated as rural. I cover with my hospice and palliative patients Towns County, Union County, Fannin County, Gilmer County, and Pickens County. So therefore, I'm in homes. I'm also in the clinic practice as well, and there have been more than one barrier that I have had to, it's not just insurance. And here recently, we've had some clinic closures, and I'll get to that here in just a minute with one of my slides that has impacted accessibility. Primary care is the foundation of a healthy community, but in North Georgia, we are obviously in a short supply. Patients often wait months in even weeks to see a provider or drive over an hour to specialty. This is near and dear to my heart as I obviously make referrals. In addition, I am a caregiver of an adult disabled sister. So I joke that I'm her medical Uber to take her to specialists that range from Chattanooga, Tennessee, as well as Atlanta, Georgia, and Gainesville, Georgia. Telemed is not always reliable, especially in our little pocket of mountains. Cell service is not always the best. There are some houses that I go to that there is no internet service. Internet doesn't even go to that area. So also our elder care, our elder patients, they are not very well receptive to telemedicine. Bottom line, when access is delayed, preventative care fails and falls behind, chronic conditions worsen, and emergency rooms take the burden. Patient impact is felt most by those who are frail, elderly, and homebound. Nurse practitioners and PAs, though, are stepping up to fill the gap, but they need support. Expanding rural clinics, streamlining licensure, and removing barriers of practice and investing in these providers is essential if we want to keep our care close to home. What I have seen firsthand is that where I practice in Blairsville, Georgia, mind you, it's right on the Tennessee, North Carolina, Georgia line. So there has been 2 clinics that have had to shut their doors because their providers have retired, and there was no one to replace those retiring providers. I remember reading a study on this, and now I am seeing it in real time. And it's very sad because some of these clinics have been open for over 30 years. So patients are very impacted. New provider, it's just overwhelming at times. The other piece of this is reaching specialty care barriers. Psychiatric specialty is probably one of the top areas that is in need in the North Georgia area. We have 2 locations that we typically refer to, Gainesville, Georgia, and also Mountain City, Georgia. These both are an hour away, one way. Counseling services are available in Blue Ridge, Georgia, but it's limited and there's a lot of telemedicine involved. Primary care practice fills the need. We put a Band-Aid on it, but unfortunately, the examples of the Schedule II, not being able to write for ADHD medications, does limit what we can help with. Other surprising barriers, insurance. Just because you have coverage does not mean you have access to care. Certain policies are not accepted. Even though on the website they say that they take the insurance, sometimes they do not. If I have a patient that has Medicare and Medicaid, there are some specialties that refuse to see them even though they have 2 insurances because the Medicaid they don't take. So that puts us to scrambling to figure out, and it's a delay in care. And I could tell you some stories of the delay of care in regards to this. Now, what ties into this as well, I want to talk to some of the folks that presented earlier to get more information, is the public transportation in North Georgia, Mountain Area Transport System, that is known as MATS. It only covers Gordon, Pickens, Gilmer, and Fannin. So this creates a bit of an issue for my palliative care patients because our biggest hospital is in Union County. That's where our ortho, cardiology, podiatry, ear, nose, and throat. That's where my Fannin County patients need to get to Union County, and MATS does not go across that county line. Then there's issue with non-emergent, moving the patient across the line. I look forward to maybe finding some resources, and hopefully with the Rural Health Initiative, things may move forward into providing more care for our patients. Now it's you. Sorry. There you go.
Hi. Thank everybody for this time today. I'm Shannon Witten. I am the director-elect of our state organization, UAPRN of Georgia. I'm also working with our Elevate program, which is our state mentorship program. And what we're doing is working on helping students, nurse practitioners specifically, transition from school training to practice. Sessions from how to complete your practice protocol, emotional intelligence, collaboration, just a lot of things that can bolster and improve nurse practitioner practice. I'm a doctorally prepared nurse practitioner and public health professional. I'm from Washington County, Georgia, where Dr. Sumner's from. I was in a collaborative agreement with her in the beginning of my practice. Having her as a physician mentor was extremely important, and I appreciate that. I tell everyone I learned everything I know from her. And on that line, I'm just side tangent. One question I want to pose, particularly to the medical board and any physicians, is would residencies and fellowship programs, as our nurse practitioner students are getting out of schools, bolster trust in us being able to release some of the practice barriers that we have so that we can improve access to care? I'm going to tell a story. I'm from the South. We love a good story. Unfortunately, this isn't a good story. It's an important story. I have permission to discuss Hannah from her mother. Hannah was a 22-year-old Black female in Washington County. She had health problems. She had hypertension, polycystic kidney disease, and she was well aware of her medical problems. Hannah woke up one morning. She was a little bit dizzy, a little bit nauseated, thought maybe her blood pressure was up, so she called her primary care. It was just a day for perfect storms. There were no same-day appointments. Our community, unlike some of the others, because of what I was talking about, we do have good internal medicine presence and nurse practitioners and PAs, as well as multi-practice practices with cardiologists, podiatrists, through our FQHCs and through the hospital practice. We have access to cardiologists and orthopedic surgeons. So we have a community. But again, it was a horrible day for Hannah. It was awful. She could not get an appointment. She went to the emergency room, was eventually told her blood pressure was up, but just call primary care again, keep trying, or get in touch with her OBGYN. She was within a week postpartum. What we know is particularly Black women are 3 times higher than their white counterparts to suffer a cardiovascular event and die following a routine delivery. This is an access problem. This is in part a cultural competency problem, but predominantly access. There are, let's see, get this right. Georgia is number 8 in the country for maternal mortality. We are number 1 in the country for economic development, which is really impressive. If we could put our economic development toward improving healthcare, we'd be somewhere. We're 32 in the country for overall patient outcomes. The United States spends over $4.5 trillion a year, and we have worse health outcomes than any other developed country in the world. It's staggering. We've got to work on this. I want to mention one solution. Working on reducing nurse practitioner, physician assistant, APP barriers. And one of these is specifically through the Rural Transformation Act as part of the big, beautiful bill. The United States has already approved $50 billion to give to states, $10 billion per state, 50% going to the states that apply, 50% at the discretion of CMS for the states that possibly most need it, but there are other regulations. So I encourage you to look at this. One of the requirements for Georgia to receive this funding is releasing some of the practice barriers for nurse practitioners. We have a bill at the House. We had almost some success last year for nurse practitioners to be able to certify, simply write a home health care order. So when a patient is in the hospital for their pneumonia or congestive heart failure, the nurse practitioner can certify an order to get home health care into their home immediately. Because we know that recurrent visits or return visits from patients going home and having a relapse of symptoms from heart failure is a huge cost for CMS. As the gentleman here was speaking earlier, I know that we are not expanding the bill in Georgia. I'm well aware of Georgia's stance here. But we do know that there have been some administrative problems with the CARE program, the current program, particularly administrative. There are only 8,000, I think you were saying, enrolled. Part of the problem is getting administrators, paying administrators to be able to enroll these patients. And we are going to see a huge number of uninsured patients hitting our state soon. So talk about that compounding the rural access issue. So I'm going to leave it at this. It's going to take a village for us to repair and improve healthcare in our rural areas. And I encourage you to look at everyone that's willing to give a hand and step in. Nurse practitioners during COVID were given autonomy to practice telehealth. And the research that has come back has showed that we compare comparably with our primary care physician counterparts. Not on every measure, but on quality measures, hospitalist length of stays for nurse practitioners that are hospitalist, and CMS quality improvement measures. So I thank you for your time.
Hello, thank you for the opportunity to be here today. My name is Chelsea Hagopian. I have the pleasure of serving as Executive Director of the Georgia Nursing Workforce Center, where our goal is to use accurate and timely data to help you make informed decisions and be good stewards. How's that? Perfect. Awesome. Thanks for the tip. So you can be good stewards of state resources. When we're thinking about the available data on the Georgia nursing workforce in particular, if you scan this QR code, it'll bring you to a page of our 2024 impact report that describes the available data in Georgia at the state level as well as at the national level. This is a screenshot of a table of the just count of licensed data from the meeting minutes of the Georgia Board of Nursing. So you can see that a total count of nurses in the state is approximately 146,000 nurses. And fear not, there are materials that you have that have this QR code as well. This is the publicly available data on the distribution of nurses in the state of Georgia. So while at first glance this looks like you can make actionable decisions around shortage areas, and it's an excellent start to data, the challenge is that it is presenting the distribution of nurses based on where they get their mail delivered. And with the assumption that nurses don't always work where they get their mail delivered, it can only be so useful as far as directing resources, identifying shortage areas, in particular for nurses across the board, including nurse practitioners. You can also see a breakdown of gender. Here's an example of a state where you can see a distribution of both the mailing address as well as the working address. And so if you're thinking about transportation as well as practice area shortage, you can toggle between the two, and you can also see commute. At the national level, there are two data sources that represent best available data on the Georgia nursing workforce. This is just showing you from the National Sample Survey of Registered Nurses. The challenge with national data is that they are indeed sample surveys. So there are considerable concerns around oversampling or undersampling, so it does not reflect the most accurate representation of the nursing workforce. This is just a comparison between 2018 and 2022. The point of this graph is, because I know it's small, is not to show you necessarily the data points, but just to show you that you can see some changes using same data sources. But again, there are concerns around over and under sampling that comes with just having a sample survey at the national level. One publicly available data source prior to the move of the protocol agreement submission form to an online module, so this was last pulled June 23rd, was a 900-page PDF of active protocol agreements between nurse practitioners, or APRNs, and their collaborating physician. Now this does have a practice address or protocol address because the requirement is for the protocol agreement to live at the practice address. So getting creative with publicly available data that we do have, you can start to see, based on a sample, here's a distribution of the practice addresses of nurse practitioners in the state of Georgia, those with a protocol agreement on file. So you can see at least a start of distribution data. Now, here are the challenges that we face in the state of Georgia. Access to that data, access to practice address data. Best collected data comes from the relicensure survey when nurses renew their license. There is an opportunity to complete a workforce survey where you enter your practice address and a few other characteristics. To date has been voluntary to complete, but my understanding following HB 1013 a couple of years ago, that mandated certain workforce data collection. However, it is still inaccessible workforce data because it's not shared. So the ask is directed data sharing to the designated state nursing workforce center. The ask is not a novel one. This is just from a regional peer of Florida, which directs data sharing to their state nursing workforce center, charged with producing timely annual reports on supply, demand, and educational capacity. And brevity is the name of the game, so that's all I have for you.
So can we speak to our Senate bill? Juliana, do you want to speak to our Senate bill?
Yeah, we have a question real quick.
Okay.
That, the total number of registered nurses that you have in the state that you had, is that showing practicing nurses, or those like me who keep my license up just in the event? So that's not maybe an accurate description of how many practicing nurses that you've got in Georgia.
I really appreciate that question because it's a data point that is very challenging to communicate, that just because we have you're a licensed nurse does not mean you're actively practicing, and it also doesn't mean you're actively practicing in a direct care role. For example, my primary role is as an educator. I teach pre-licensure nursing students. So while I do maintain a small active practice as a nurse practitioner, my data point in this number is not representative of the employed and actively practicing in direct care role workforce. So absolutely. So one of the major national data points comes from the biennial National Nursing Workforce Survey. That's a collaboration between the National Council State Boards of Nursing, National Forum of State Nursing Workforce Centers. There was a data point that said it was fall of 2023, Georgia is among the lowest ratios of employed RNs per population at 750 per 100,000. But again, that comes from national data, and there are concerns around oversampling, undersampling. That particular data point was also pulled using data from BLS, and we know that excludes self-employed workers. And so you can think about just the percentage of nurses that might be self-employed that are not represented in that as well. But also, just because employed does not mean actively practicing, and actively practicing in a role that requires a nursing license. Excellent question. I really appreciate that.
Hi, I would like to follow up on that. So the licensing board for professional counselors, social workers, and marriage and family therapists under the Secretary of State also has the same dilemma. When we survey our LPCs in Augusta, I've given you the map. We're the only organization I know that, louder, got it. So we're the only organization that I know that actually has a map that puts the 4 disciplines, the psychologist, the LPCs, the LCSWs, the LMFTs, that's that map. There are less than 2,500 psychologists in our whole state. We do ask for them to participate in the survey also. Are they practicing at a university? Are they practicing at a hospital? Are they available actually to the public? So when we did a quick survey of our LPCs in Augusta, and you'll see the number. When you see the number, that's just the number of individuals based on their mailing address. When we talk to them and we interview them and we survey them, we've discovered that in Augusta, there's an Augusta, South Carolina, and that's where they all go, even though they live in Augusta, Georgia. So we also, under our licensing board, have a dilemma with not knowing exactly who is actually out there to practice. So we get calls every day from the public, please help me find a professional counselor in my area. So our 9,000 members, we do ask them to put them on our personal directory so we can look up and see, are you available to the public, or are you working at a hospital or an agency? So we are able to provide the public, as a nonprofit, some information to find a counselor in that area. But a lot of the times in rural Georgia, even with our we have a monthly rural roundtable, and they're telling us they're taking clients from 5 to 7 counties away from where they're practicing. So having the data would be extremely helpful in our push to get more LPCs in rural Georgia, because we know without mental health, you're not going to have great physical health. Thank you.
If I may make one more point about data, specifically for the Georgia nursing workforce, we would love to answer a number of questions in an actionable way. Problem is, if anyone asks where are nurses working in Georgia, the answer is no one knows at whole, which is seriously problematic, and we're tremendously behind. So really the ask is around that SB 131 from the previous legislative session. I know that there was some language and it didn't completely go through, language change, but mandating data collection, so rather being voluntary to complete, because I know that every time we all get surveys, we love completing them if it's voluntary. But if mandated data collection as well as directed data sharing to this designated state nursing workforce center, as the complexities of nursing workforce data requires specific expertise to tease it out. So that's my ask. Is that what you wanted to talk about?
Yeah, and just one more point is that with workforce data, we're so restricted that we have several, especially psychiatric nurse practitioners, who are, in their living room in Alpharetta, Macon, wherever. They hold a Vermont, Washington state license because it's full practice authority, and they're doing psychiatric mental health services in those states. They're not providing that care to our Georgians. So where your practice address and what you do would be very, very helpful to know if our nurse practitioners are actually serving our Georgians.
Indeed. Without good data, you cannot possibly make good decisions.
Any questions?
I have a question of Ms. Gale. Good. There's somebody in my community that he was born with transposition of the great arteries, and he has had like 4 or 5 surgeries, 3 of them within the last year. He had some serious mental health challenges once he came home, because he was here at Emory. He wound up going back to Texas where he had his original surgery when he was born, and came home and had fallen into serious, and y'all will see him at the Capitol. He had fallen into serious mental health challenges. His parents didn't know what to do, they didn't know how to help him, and they can't find anywhere that can help him. And so he has started a foundation this year, and this young man, he's 22, whom I love. If you're watching this, Ben, I love you. But anyway, the challenge to getting that, and so there's some places like in Texas, there are some counselors that are there. They wanted to continue seeing him, but then the reimbursement doesn't work across states and stuff. So to your point about having a center where they're actively practicing people that can help, whether it's counselors or whatever, we need that, not to, for somebody like me, maybe even Dr. Sumner, I don't want the state of Georgia to say, you haven't practiced in 10 years, so you're surrendering your license. That's why I think we see where there's not a mandate for that. But we do need to know that we need this data, because they have been pouring through the internet for months to try to find some licensed counselors, and they can't find them. They can't find how the reimbursement rates and stuff would work. So we need to look at that. I don't know how we need to look at that. We need a lot of input, I'm sure, but we need to look at that. Thank y'all for bringing that point up.
I'm tremendously happy to help with how to get started with the data, as far as if you didn't know where to start volunteering myself. Happy to help.
So I'll just mention real quick that Georgia being #1 again in the U.S., y'all in legislation were the first to pass the Professional Counseling Compact Law 4 years ago. Extremely exciting. It's just opened up now. One of the things that lawmakers asked me at the Capitol when we were asking for the PC Compact, oh, LPCs are going to leave because they get paid better in other states, and they do. But no, Georgia LPCs stay here. So we know that by having a real track in clinical mental health from high school on, we are going to get our young to be more committed and to stay in the area. Because again, here's the PC Compact, Professional Counseling Compact. Everybody said Georgians are going to leave and be able to practice in all these other states so easily. They're not, they're staying here. So we know if we can get them involved in their community and they have education in that community, they'll stay in those communities. We hear that from our rural roundtable every month. Thank you.
Thank you so much. Any other questions? I know Representative Hagan had to leave. Does anybody else have questions? Does anybody have any final comments that they would like to make on the panel here? No? Okay. So I'm going to end with this. I want to thank all of you for your time, your attention, contributions today. We've heard valuable perceptions on the challenges and opportunities in improving access in internal medicine across our state. And it's clear that our patients, providers, and communities alike are feeling the effects of limited access. At the same time, we've also learned about promising strategies, from strengthening residency programs and supporting our workforce to technology and care models. The testimony and discussions we've gathered will help guide us in our recommendations. Our goal is not to understand the problems, but to identify solutions that are more responsive to the needs of the people we serve. We will continue this conversation later in November to review our report, and I look forward to working together next session to strengthen access to care in every corner of the state. And with that, our meeting is adjourned. Thank you all so much.